here at Red Hutch, and I helped co-chair this event last year. We're so thrilled to be able to put it on again this year. And I specialize in breast cancer and also brain metastases for those who maybe haven't met me before as a radiation oncologist here. We have an exciting day ahead of us today. I've seen a lot of familiar faces returning from last year. So that brings me so much joy, and I'm really happy that you took the time to make this part of your weekend. Also want to say hi to everyone who's calling in virtually. So we have a large crowd who's participating, hopefully from a comfortable place. And we had a lot of people even calling in from out of state last year. So that's the goal of this event. We want to support patients and caregivers dealing with metastatic breast cancer, no matter where they are in their journey or no matter where they live. Before we begin too, I do want to acknowledge that there are some of us from last year who were not able to attend this year. So we did want to give a moment of silence for them. We could take a deep breath. We know this isn't the easiest of times in many ways, but I want to assure that this is a safe space for you today. I feel like we are building a community, and in some ways I feel like I'm surrounded by family, which makes me less nervous. I hope that everyone here comes away with some raised awareness. I feel like often the decisions and things that we do on a day-to-day basis are based on our awareness. And I think the goal of this conference, Metastatic Breast Cancer from Surviving to Thriving, it doesn't mean everyone is going to be dancing and having the best time ever every day. But what does it mean, at least when I thought of this title, what does it mean to thrive? I think it means to have some sense of control amidst everything that's going on. And I tell this to hopefully all my patients, I try to, but one thing that can really help navigating a cancer diagnosis is to focus on the things that you can control. And as physicians, in the clinic, oftentimes those are kind of short visits. We get to touch on the things we have to, but not all the things we want to. And so we've created this space where we've got a diverse panel of speakers across many different domains of living with metastatic breast cancer, not just in the clinic, but outside the clinic. And so I hope that you can really gain a better breadth of understanding of what are some of the things that can help you, help your partner, help your family during this time, and things that you have control. I want to make a land acknowledgement statement for the Coast Salish peoples of the land, and it touches the shared waters of the tribes and bands within the Duwamish, the Puyallup, the Suquamish, Tulalip, and the Muckleshoot nations. This is what I look like. And a few reminders. This event will be recorded, so please bring out your best jokes. The link to recording will be shared with all registrants in the post-event email a few days after this. For those attending virtually, you can post your questions using the chat function. We will see your questions, and we'll try to address those as well. We really welcome your participation. Help make this even better. If you accidentally leave, all hope is not lost. You can click the link to join back. And for those in person, if you accidentally leave, all hope is not lost. You can walk back in. Please ask your questions. At the end of each talk, we'll have microphones that we pass around. want to speak into the mic so those attending virtually can also hear you, unless there's something you really don't want them to hear. And we'll have a feedback event form at the end. We really appreciate those responses we got last year. We took that into consideration and made a few small, what I hope are improvements for this year. Here's an overview of what we'll cover today. We'll begin shortly after me with our keynote speaker, Dr. Heather Parsons, who's a new breast medical oncology faculty joining us from Memorial Sloan Kettering. So really excited to have her and welcome her into Fred Hutch, and kind of maybe this is her debut speech. It's really cool. We'll get into finances, with the theme focusing on practical aspects. And then we'll move on to self-care across multiple domains, including nutrition and exercise. There will be free lunch, and then we'll continue with this theme of self-care, this time focusing on caregivers and loved ones. We have another guest speaker flying in from California, Dr. Silvia Corral, who will help with speaking about patient advocacy. I do have a relationship with her. She is my mom. And then we'll finish up by touching about research and clinical trials. And throughout this, again, really welcome your questions. There's no such thing as a dumb question. We're not here to judge each other. We're here to support. So I think we are ready. We'd like to welcome Dr. Heather Parsons to the podium. She's the program head for our breast oncology program at Fred Hutch. She's an associate professor in the clinical research division, the Maudslin Endowed Chair in Breast Cancer Oncology Research at Fred Hutch, as well as associate professor in Division of Hematology and Oncology at University of Washington School of Medicine. So Dr. Parsons, welcome.
This one, or yeah, okay. Does this one work? Yes. Should we do this? All right. Thank you, Ben. All right. Wait, yeah, and this is gonna go. Does this go? Yep. All right. Great. Can everyone hear me? Okay. Yeah. No. No. Can you hear me? Okay. Now. Now I'm gonna have to lean really low. Hold on a second. We're gonna have to fix this because it's a little silly. Maybe I'll just use the mic. Yeah. Can we do that instead? Maybe. Yeah. Does this work? Nope. It's not on. Let's do. How about now? And we're going to turn this one off so it doesn't do a crazy thing. All right, good. Thank you, everyone, for being here today. And I'm just and thank you, Ben, for hosting and for leading this really important day. I'm thrilled to be here. I'm thrilled to be here in Seattle and with this at Fred Hutch, and look forward to meeting many of you. I'm going to first just talk about what has been a passion of mine for more than 10 years, and used to be something that was sort of far afield from what people were thinking about in clinic, but now I'm happy to say has really moved into the clinic. But I know there are a lot of questions around this as well, about liquid biopsy, what it means, what it doesn't mean, what the potential for it is, what we know now and should use in the clinic, and what we might know in the future. And so I'll hopefully be able to answer some of those questions, and then at the end we can answer more if you have them. So we'll start out. So simple blood test, sometimes not so simple, but how liquid biopsy is changing metastatic breast cancer care. These are my disclosures. So I think it's helpful to first just step way back and say, what is a cancer biopsy? I know everybody who is dealing with breast cancer has had a breast cancer biopsy at least one time. But it really is a sampling of cancer, can be tissue or blood or another bodily substance that's done to assess how a cancer appears under the microscope, proteins that are expressed by a cancer. So this might be something like HER2 or ER, estrogen receptor, or progesterone receptor. What gene expression levels in a cancer look like. We might think about an oncotype test in this way. Gene changes in a cancer at the DNA level. So you may have heard of an ESR1 mutation or a PIK3CA mutation, things like that. And all of these can be gathered from the tissue. So if we take a sample of a tissue, we can figure out a lot of these or all of these. And historically, we've really only been able to look at this last one in the blood. This is changing, but it's still mostly true for the tests that we use in clinic right now for liquid biopsy. So that's important to keep in mind. And so tissue biopsies are important and they're essential to care for in breast cancer, but everyone knows they may be challenging to perform. They certainly can cause discomfort for some patients because of the location of the biopsy site or because of something about how the patient is doing. It might not be safe. It also may not give us all the information we want and need, and is not really feasible to do frequently and over the course of disease. So we might do it one time or two times, or even sometimes a little bit more than that, but we don't want to do it every few months, certainly not. And so it begs the question, so then why not just use blood? So we've been searching for cancer in the blood for a very long time. This is not brand new, although sometimes it feels that way. We have blood-based biomarkers that many people will be familiar with that are things like CA2729 or 15-3 CEA. These are all things that are considered what we might call tumor markers. We also know that circulating tumor cells, or CTCs, are something that's been available for a long time and is approved by the FDA for use in metastatic breast cancer. So why does this seem suddenly like a new thing that we're using? And well, first, it's helpful to look at this curve, this what's called a Kaplan-Meier curve on the right. And I am going to show a few of these, so I'm going to take a minute just to explain what it is, because some people may be very familiar, but others may not. So Kaplan-Meier curves look at how we're measuring how well a treatment usually is working by looking at how many people might remain without progression of disease or without what we call an event over time. So time is on let's see if this works. No, here, let me use this pointer. Can you all see the pointer? Oops. Yeah, okay, great. So here's time here, and then on this curve here is the proportion of people who remain without their cancer growing or progression-free here on the y-axis. And so when we see the curves here, if we want to know if something's working and we're comparing one thing to another, we want to see that they really separate nicely and widely. And so what the investigators did here in this study with CTCs is they asked if people had CTCs that they could identify at the beginning and they were starting on treatment for metastatic breast cancer, they asked, if we start the treatment, do those CTCs go away? And if they didn't go away, meaning that the cancer hadn't really responded or wasn't shrinking or dying as a result of the treatment, they would, for half of the people, switch them to a new treatment, and half of the people keep them on the same treatment, and then ask if the switching treatment early made a difference for the patients. And unfortunately, you can see here that these curves don't really separate very nicely. Maybe a little bit here, but not dramatically so and not meaningfully so. And this was the same, this is also true for how long people lived. It didn't help people live longer. And so this was a disappointment and asks sort of, why do we think this is different now? Why are these tools or things better now that we might consider doing this again? And I think it's important to know that the technologies we're talking about now are orders of magnitude more sensitive than the ones that we were using before. But maybe even more importantly, our current therapies are more effective. The treatments that were being used in this study that I'm showing were actually just sort of run-of-the-mill chemotherapy. They were not targeted in any particular way. And when we pair these two things together, highly accurate diagnostic tests with highly effective therapies, I'm hopeful and I believe that we may be able to really change things. And so that's why we think this might be different. So then what is cell-free DNA and where does it come from? This is what we're talking about when we talk about liquid biopsy for the most part right now. Cell-free DNA is single-strand pieces and double-strand pieces of DNA that are in circulation. Those are released by cells mostly when they die, some other ways too. They're cleared by immune cells that are in the liver and then also by enzymes very quickly within just a few hours. So it's a very nice real-time marker of disease. Circulating tumor DNA or ctDNA, which is the portion of the CF DNA that's coming from the cancer cells specifically. So cell-free DNA is coming from all the different cells in our body, white blood cells, liver cells, heart cells, whichever cells that are there, but ctDNA is the part of that that's coming from cancer. And this shows the signs of how the cancer cells have changed that can include gene mutations, how the DNA is arranged, which genes are active, and then chemical changes that can affect how the genes behave. So these are all different kinds of things we can figure out by looking at the ctDNA from the blood. And we see higher levels of ctDNA with certain cancer subtypes, higher burdens of disease, and then specific sites of metastases. These are all things that can affect how well we can detect the ctDNA or not. Some other things you might hear about or when we talk about cell-free DNA or ctDNA are things like tumor fraction, which is pretty simply just a portion of the CF DNA that's coming from the tumors, the ctDNA. It's usually expressed in a percent. Minimal or molecular residual disease, or MRD, which is not what we'll really talk about today very much. We usually think about it a little bit more often in earlier stage disease, like stage 1, 2, or 3, but we can think about it in metastatic or advanced breast cancer sometimes. But this is trace amounts of cancer that remain in the body and are detectable by a liquid biopsy that are not seen on imaging. So if we don't see cancer when we do a scan, but we see it in the blood, that would be considered minimal residual disease. We use that usually when cancer therapy is all done, and the term really comes from our blood cancers, leukemia, multiple myeloma, and we're sort of reappropriating it for solid tumors. We can think about ctDNA as a tool across the disease spectrum, all the way from screening and diagnosis, which has all the way to really thinking about detecting resistance and everywhere in between. In breast cancer, we really focus on these 3 aspects because screening and diagnosis, we already have mammograms, and the studies that have been done in the screening and diagnosis field in breast cancer haven't looked very good. So I'm hopeful that may change over time, but that's not the case right now. It's really a rich source of cancer-specific information, which is why it's so special. We can look at mutations, copy number changes meaning things like HER2 amplifications and others, gene fusions, DNA methylation. These are all different ways that we can understand the cancer. And when we do these tests, it's important to remember, too, that each test is very different. So every ctDNA test is not the same as the other one. And we want to ask what our question is before we decide what test to use. So because when we think about the tests, a test that wants to look at many, many different features of the ctDNA will be better at that only if there's a high level of ctDNA. Whereas if we want to look at very, very low levels of ctDNA, we look at fewer spots and fewer changes. So these require different approaches. And it really all comes back to what you want to know. So it's helpful whenever we're doing diagnostic tests, no matter what it is in clinic, that we ask first, what are we trying to figure out and what are we going to do with the test results when we have them? Because if we don't know that, we can't answer that question, we probably shouldn't do the test in the first place. And ctDNA, we can answer hopefully lots of different questions, but we really need to focus first on what it is we want to know. So in advanced cancer, ctDNA, I think there are a few questions that we can think about that can be ones we want to answer. And I wanted to go through what the evidence is right now that we have for being able to answer those questions. And start out with just a simple question of, can we substitute ctDNA for a tissue biopsy when we're thinking about those DNA level changes? Can we predict a cancer's response or resistance to treatment? Can we monitor a cancer's response to therapy? Can we see if it goes up and down the same time the cancer is growing or shrinking? And can we understand prognosis? So there's probably many others, but those are some of the big ones that we like to think about in advanced cancer and want to ask with liquid biopsy. So first, just asking that question, can we use the liquid biopsy to ask the same questions that we would ask with a tissue biopsy? And this is just a fancy figure on the right that's showing that yes. So when we look at tumor mutations, DNA level changes in the blood, and we look at the same ones matched in time in the tissue, do we see the same thing? And this was looking at patients with some different kinds of metastatic cancer, and we saw that about 90% of the time when we looked in the blood and we looked in the tissue, we saw the same thing, which we thought that's a pretty good overlap. And that's been shown in a lot of different studies, which is very encouraging, and is sort of why that we think that we can use liquid biopsy to substitute for tissue biopsy. And ctDNA does come from multiple metastatic sites, so that's helpful when we think about what might be going on with the cancer. We can actually see more kinds of changes that might be happening in the cancer because we're not just sampling one single site. We have many commercially available cancer, what we call panel tests, that kind of do the same thing, where they're looking across the DNA from the tumor, the ctDNA, to look at what changes might be happening in the cancer. The performance of each individual test can vary across tests. That's for the probably for the physician to be thinking about. It's important for you to know as a patient, though, that each individual test can be a little bit different. And I'll talk a little bit about why that's important in just a minute. So I think we can check that box that we can use that blood test to substitute for tissue tests in many cases. So what are we looking for on a ctDNA panel test in metastatic breast cancer? Our list used to be very short when I showed this slide. It's growing longer, which is exciting. And I think it's growing longer almost not by the day, but certainly by the month maybe. But in terms of the genomic alterations that we might see, I think one that most people may have heard of is ESR1 mutations, and we have an approved drug, elacestrant, and we have a lot more coming in that setting. And then there's a long list of others, including AKT pathway alterations, which include PI3 kinase mutations, and there are a few drugs for that, HER2 mutations, germline, BRCA1 and 2 mutations, germline, PALB2, and somatic, meaning coming from the cancer, not from inherited genes, alterations, something called microsatellite instability, high tumor mutational burden, and NTRK fusions, which are very rare but very treatable if they're identified. So these are some of the alterations there and more common ones that we might be able to use these specific drugs for. It's important, though, to know that if we don't see these in the blood when we look on a liquid biopsy test, that a negative test, meaning it's not there, is not definitive if the ctDNA level is overall low. So because you can imagine if it's a low level in the first place, it's hard to detect things. And so that's important for us to remember when we're doing these tests. So if we can do that, we can substitute ctDNA for tissue biopsy. We can predict a cancer's response or resistance to treatment, meaning looking for those alterations specifically. Those are what we're using those tests for now in the clinic. So what about monitoring and prognosis? So this is a study from now a few years ago, but looking at just a simple measure of what's called tumor fraction. Again, that's the sort of portion of the cfDNA that's coming from the tumor, and showing that if you looked at tumor fraction of less than 10% versus greater than 10%, there was a big difference in patients with metastatic triple-negative breast cancer and how long people lived. It was the lower ctDNA level was significantly associated with better prognosis than higher levels. But then the question here becomes, is that a helpful test? It's interesting and it's useful for us to know from a biological perspective, but does it help us in the clinic if we have a test that says this is a high level or a low level? What would we do differently? And I think that's the big question that we don't have a good answer to yet, but this is important information. And similarly, this is a little bit of a different sort of getting more at a useful a question that we might be able to act on,
is this is a result from something called the Bio-Italy study. So this is a study of patients with hormone receptor positive, HER2 negative metastatic breast cancer, getting their first therapy for metastatic disease. And they measured the ctDNA and looked at whether the levels dropped after one cycle of disease, and then how that compared with how well people did over time in terms of the cancer responding to treatment. And people, we saw a significant difference in people who had ctDNA, what's called clearance, meaning they couldn't see it on the test anymore, any evidence of ctDNA. Doesn't really mean it went away, that the cancer was gone. It just means the test couldn't detect it anymore, but that was a significant difference. So this is moving towards maybe this is something we want to use in the clinic, but this is a retrospective study in a small population, so not yet something we would act on in the clinic, but encouraging. So then we have the SERENA-6 study, which I'm going to actually flip. I reversed my slides, but this is a really important study. I'm going to spend a little bit more time here because it is so important, looking at something called ESR1 mutant ESR1 surveillance during first-line treatment of breast cancer. So ESR1 mutations are changes in the ESR1 gene that happen during aromatase inhibitor therapy, and that's for those who are not familiar, that's a very, very common therapy for metastatic hormone receptor positive HER2 negative breast cancer. And so the cancers develop those mutations because they become resistant, they become sort of smart to the treatment in front of them, and they develop a way around that through these ESR1 mutations. And they develop, if we give aromatase therapy in maybe even probably more than 40% of people with this kind of breast cancer. They can be detected by the ctDNA analysis, and here the investigators call these blood ESR1 mutations, and they do retain partial sensitivity, so that even with these mutations, some of the endocrine-driven drugs like fulvestrant work in this setting. And so the SERENA-6 study came out of this idea that maybe if we could detect them sooner, we could detect these mutations from the blood, and we change therapy to a more effective drug, maybe people would do better. And so the SERENA-6 study took patients, it was more than 3,000 patients who were receiving they were already on their treatment for metastatic hormone receptor positive HER2 negative breast cancer. They enrolled in the study, and then they were tested every 2 to 3 months for ESR1 mutations and underwent scans, which was part of their usual treatment. Patients kept doing this over time, and when they had a positive mutation, they then underwent a scan to see whether the cancer had also grown on imaging. If it had, they were out of the study and went on to the next appropriate treatment. But if they hadn't had a visible change in their cancer on scans, they were then randomized to either keep going on their treatment as it was, or to switch therapy to a new drug called camizestrant. And that was in combination with the CDK4/6 inhibitor that they had been receiving, which is part of the first-line treatment. And they were sort of followed again to look for a development of resistance. And so this is a really exciting study. We were all, I think, really excited to see what the results looked like. And we saw these results back at ASCO in this year. And I'll show them to you here, and then we'll talk about what they mean. So excitingly, we saw that when the patients switched earlier, they did, here you have the green line. The top line is the group of patients here who had switched to the new drug, camizestrant, and kept their CDK4/6 inhibitor. And in the blue line here is the aromatase inhibitor plus the CDK4/6 inhibitor. And so at first you say, well, that's great. We should just start doing this right away. That's a terrific result. And it certainly is encouraging that it worked. But then you have to dig in a little bit to the details of what was happening in the study. So maybe I'm giving myself away. Should we use these results to guide therapy for patients now? So the first question is just, what about crossover? So how do we think about this study? Because if you think about what happened in the study, the patients first were all going on the same kind of therapy. They were on this aromatase inhibitor and CDK4/6 inhibitor. And then they had what we call molecular progression. So again, meaning that they could see the change in the blood from the ESR1 mutation, but no change in the cancer on the scan. And then half of them switched to camizestrant and half continued. And then they measured if they had progressive disease, they were comparing this group here to this group here. But what we really wanted to know is what if this group, the ones who hadn't switched, who kept going, instead of calling this the time of progression, what we really should have done is had them switch to the treatment now and then compare this to this, right? But that's not what we did. We compared this first group here, who had gotten now really two sets of drugs with their aromatase inhibitor before and now camizestrant next. And we're comparing them with a group who only got one kind of drug, the the aromatase inhibitor, and then measured progression. So it's not in my mind, nor in I think in the mind of a lot of people who saw these data, that this wasn't really a fair comparison, because what happened was they weren't allowed to cross over because this drug isn't available in the community yet. So you couldn't just stop the study and then switch to this drug that the other group was getting. You had to just switch. And actually, many people switched over to chemotherapy. So not also maybe a fair comparison. So I think it's disappointing to us, but I think is an important illustration of just how important it is to do these studies well, so we can come back to you and say, this is what we should be doing in clinic for you, and how we should be taking care of you is to be measuring this blood test every 3 months and then maybe switching therapy based on it. So I think we still have a lot to learn about this study and the results, but I think it is coming, but it's just not, we have some work to do still. So I would say not yet in terms of using the SERENA-6 data to guide therapy right now. I think some people might disagree with that. There are some other details that I'm not going through here for lack of time, but it's still, it's an exciting study and important that we build on it. So I think our data in terms of whether we can monitor cancer's response to therapy and make a difference for patients is not yet there, but coming, and I think it will be the case, but we have some work to do to prove that that's important. And then in terms of understanding prognosis, I think we have a lot of data that says this is associated with prognosis, but then the question is prognosis a useful tool for us in clinic to be sharing or not? And I think that's a little bit more nuanced and part of a conversation. It doesn't usually change how we behave and what we recommend. So our understanding and clinical use of ctDNA is really rapidly evolving. And again, some areas have much more evidence for use now than others. So an important, I've alluded to this a few times, but I just wanted to really go in on it, was just that one important challenge in ctDNA interpretation is false negatives. So all of these tests that we're talking about generally have limits of detection, meaning a level of below which the test doesn't work, doesn't detect what you want it to find. And these ctDNA levels in advanced cancer can vary very significantly. They can be, down to a few parts per million and up to 80% of the cfDNA. So really quite a large variation. And they can be very low when the disease is under control, when there's a lower overall burden of disease, when there are lower shedding tumors, for example, in hormone receptor positive breast cancer, tumors in certain locations, for example, in the brain. And so a negative test doesn't rule out a variance, but helpfully now we're seeing on tests the result of tumor fraction, which can tell us then if the tumor fraction is high and we don't see a result of a variant, that makes us more confident that that is really a true negative result rather than false negative. But it's an important part to understand when we think about these tests. There are many interventional studies underway. I wanted to highlight just one of what we're working on now, which is a little bit out of the box and different from what we've talked about so far, but I think is a hopeful study and an exciting one. This is called the Stop HER2 study. So this is a question here is to measure, can we measure MRD? This is minimal residual disease, but in metastatic breast cancer to guide treatment. So this is the setting of HER2 positive breast cancer in patients who have been on therapy for at least 3 years and who don't have any evidence of their cancer growing. And this is a setting in which increasingly we're seeing more of these settings where people are on their therapy for a very long time and with good control, and we don't know if it's safe or the right thing to consider stopping or interrupting therapy or not. And our therapies, we know, have a lot of toxicities, both in the form of physical toxicities, but also financial toxicity, time toxicity, other certain psychological toxicity. And so is it safe to interrupt therapy, and can we use ctDNA as a tool to guide that? And so this is a study of patients who want to enter the study and then who can either enter cohort 1, where they just keep going on their therapy. They participate by participating and donating blood, as well as undergoing scans every 12 weeks. We're following them for 10 years. But the cohort 2 is, I think, the exciting one, is where patients who want to participate and want to stop their therapy and are followed with scans and visits with their physician. And then if they were to develop progression of disease, they restart their therapy. If not, they continue off therapy. And we're also following them for 10 years. And this was a study we were not sure how enthusiastic people would be, but it's completely enrolled and very quickly, and it will report out probably next December at the San Antonio conference. So I think this is just one of what can be many studies asking similar questions, but an exciting time to have a tool and a therapy that can pair together to hopefully really change how we care for patients. Other directions, so we are looking at ctDNA and other liquid biopsies, which are very rapidly evolving, and we are doing a lot of planning of clinical trials to test, again, how well and how long, whether our therapies can make a difference in how well and how long patients live. And that's really the thing we need to keep in mind as a research community, is just that we're measuring the right thing when we're looking at our studies. There are a lot of different ways we can use ctDNA and cfDNA that can give us some very valuable data. So I just mostly focused on mutations in the DNA, so letter changes at the DNA level, if you will. But there are a lot of other things that we can look at, like chemical changes or methylation, size of the fragments of the cfDNA, things like nucleosome footprinting, which is related to which genes are being expressed or not expressed. And all of these are things that are under study in terms of looking at whether we can understand a cancer better, and then hopefully use that to better guide therapy and take better care of patients. And then this is another sort of additional way to think about ctDNA, is because the thing that has limited us is really the amount of ctDNA that is present. A close colleague and collaborator of mine worked with another collaborator to think about, could we instead boost the level temporarily of ctDNA and then measure it and then be able to see more of it? It clears very quickly. So once you interrupt it and then stop, it will go away again. So they did this in mouse models first, but are working very hard right now to develop this into a clinical trial that will hopefully start next year. So in conclusion, in metastatic breast cancer, ctDNA to identify somatic alterations for therapy guidance is established, but there are challenges remaining in determining meaningful ctDNA level changes. Our ctDNA assay characteristics vary quite significantly, and using a fit-for-purpose test, meaning a test that's going to answer the question you're asking, is critical. And finally, our evolving ctDNA approaches interrogate features beyond genomics, so methylation, fragmentomics, that can better characterize cancers in real time. And I'm hopeful and expect that these will be tools that we can use in clinical care in the future. So thank you so much. I'm thrilled again to be here in Seattle and look forward to any questions you have.
My name is Dr. Silvia Corral. I'm Silvia. I'm Benjamin's mom.
Oh, hello. Thank you.
But you're welcome. But one of the things, actually, I got no evidence of disease with triple negative.
Mm-hmm.
And
wonderful news. Congratulations.
Yes. And of course, I was terrified because there's nothing to do
Right.
once you get there.
Yeah.
And you don't monitor and you don't know what's going on until it's in your liver, your lung, or your brain, or your peritoneum, or whatever.
Right.
So Tiger Lily had a study that enrolled triple negative and circulating tumor DNA every 3 months for 5 years. And I enrolled in that study, and I want to tell you that there's something that you did not put on there that was really important, which is the benefit for me as a patient to know that my cancer was growing, that my cancer was present, because I had intermittent positive circulating tumor DNA, which was frightening. But I said, okay, what am I doing? Because there is something about the treatment of breast cancer and metastatic that we as patients have to do, that has to do with all the complementary alternative and diet, the metabolic terrain that you create. And when that happened, I'd go, okay, what can I do? Well, I'm here now 14 years later, but I did have episodes of positive circulating tumor DNA. And I believe it helped me get through those 5 years. So
Thank
I just
you.
wanted
No,
to.
that's very important. And, you know, I focus here. I have a different talk that I typically give for patients with earlier stage disease, and that involves that for sure. And it is becoming more common for people living with metastatic disease to have these kinds of situations, but I typically haven't included it in this talk because it's still unfortunately very rare, and so can be a little bit, I don't want to say off topic, but I want to make sure we're speaking to the specifically to the audience. But I completely agree with you that is a really critical piece for people who are, when we're thinking about long-term follow-up for patients either with early stage or advanced disease. And that's why I too think that when I say we talk about clinical utility and the usefulness of a test, we have to think about what the different kinds of usefulnesses are. We usually measure where, the hardest, most common endpoint, if you will, would be survival, but that certainly doesn't capture many, many, many things. And so we need to think about, walking back from that as the only endpoint and other things that go with that. And so I usually say, and I think I did say here, but just that we want to make sure these tests are helping our patients live better and longer, and that better should include other things like what you're speaking about. So I totally agree with you. Thank you.
I got confused of what the benefit was, and I'll tell you what I heard, and you can help me. So what I'm hearing is that getting that feedback, it allowed you to see that there was cancer producing, and so most of us would freak out at that. But you're saying it gave you peace of mind that you.
No, it gave me a wake-up call, like what was I not doing to take care of myself? And I suddenly, okay, well, I need to go back to Reiki. I better get back to
I understand.
and I redid what I was in control of.
Got it.
Right.
Got it. That makes a lot of sense. Thank you.
And then next test would be negative.
And I think the
That
other
is
thing is,
wonderful.
one interesting part is how these tests have been, and I don't know what test was part of the Tiger Lily study, but the test I didn't get into this piece because we're focusing a little bit more on the tests we typically use in metastatic breast cancer, but the minimal residual disease tests are very different and have become so specific that the false negative is actually, false positive is almost totally unheard of because they're based on patient-specific assays that are custom developed. That's not what I was talking about here. This is a different set of tests. Also, why the kind of test that we're using is so important when we think about what's the question we want to answer. No.
I just wanted to clarify, so these are these are blood tests you're talking about that potentially. So like when I was biopsied, I had to like go on a drug, and they like took a needle and like stuck it in, and it was like a whole thing. So this could potentially be something like, I go get blood work every month. It wouldn't be every month, and they just take a vial and they check it in that. So it's like, you're saying it's significantly less like invasive.
Oh, yeah. So this is exactly
lovely.
that. So they take typically 2 tubes of blood for one test.
Okay.
And the times, you certainly don't need it every month. And one of the things that's an issue with these tests is they can be very expensive. They are very specific about not billing to patients. And so there, other things we don't, healthcare system type of things that we won't go into now. But but yes, you can usually do it when someone's first diagnosed with advanced cancer, and then at the time of treatment switch is usually when I would do another test. So when we're thinking about what is the next treatment we want to use, they come back very fast within about 7 days typically.
Oh, wow. Okay.
And so the results you can have in hand to make a treatment decision. They don't always, many times that it doesn't tell us anything that makes us do something differently, but it can enough of the time that it's important to do the test. Okay. It's not a test, again, you don't need to do every month or even every 3 months if cancer is really well controlled. The SERENA-6 study that I was talking about, that sort of asks a different question, which is, should we be doing them more frequently to monitor the cancer and then potentially change the treatment based on that change? So I think we're hopeful that will be important and meaningful for patients, but we don't know the answer to that part yet.
Okay. No, awesome. Thank you so much.
Sure.
That's so good to hear.
Yeah.
I think this is on. Yes, I'm over here.
Oh, hey.
Excuse me. My metastatic cancer was found 3 years ago, and I'm on an oral chemo. Mm-hmm. None of this, I have frequent scans since then, and they all show no progression, no new lesions, nothing. A couple of people on my team have said maybe that's because it's been treated, and I'm wondering if I'm assuming that at some point we'll do a PET scan or something to find out it's in all my bones from skull, all my large bones, skull on down. I have no bone pain.
Good. That's wonderful.
Miraculous.
Great. Yes.
I don't know why. Everything's black in the scans. Would blood tests show if it is active somewhere? Is that a possibility?
So it depends. And one of the things I think you bring up as an important one is the cancer in the bone is so hard to see from scans. And even when it's treated, it actually can look worse for some people. And so that always is really hard to sort out and to understand what to do. And so a blood test, if a blood test was negative for you, that would be encouraging, I think. If it were positive, it doesn't mean that a single blood test being positive I wouldn't do anything differently. If everything else looks the same, it's another piece of information we have in addition to how you're feeling, how the scans look, how your other labs look. But it can be an important piece of information that can over time could add another piece of the story to tell how the cancer is doing. All of this is hard because we don't know, again, the scans are not by any means perfect. And so having another tool like this can be very helpful. And that's another place we are studying is how can it be used to monitor cancer that is hard to monitor.
We have some good questions from the virtual audience,
Oh, terrific.
some that are related to this. So one is, do the test results mean different things for people with bone only versus people with solid tumors?
That's a great question. I think as I was just saying, it's really the potential for these tests in that setting is, I think, big. And there was a study that a colleague of mine did with Foundation Medicine, which is a company that has one of these tests, and looked at bone, the changes in presence or absence of the ctDNA with bone-only metastases, and they saw that they were able to detect it. So I think it is again a potential area for an important area for study. And some of this is just about doing getting the resources and the infrastructure to do these studies prospectively to understand it. But yes, I think it's a really big area of use for these tests. We don't totally know yet.
And there's another question. This is a good basic one, but there are tons of cells in the body. I know most of the cells have some DNA, but there are some differences. So when you get samples, how are you able to tell if a DNA sample is circulating free DNA or circulating tumor DNA?
That is a great question and tells me I should have answered it better at the very beginning, because the way that cancer is different from and I think what these tests all take advantage of is that cancer is a disease of the genes of the DNA. And so all cancers, even what we call quiet tumors, meaning they don't have a lot of changes in the DNA, they still have some. And so the way that these tests work is by specifically looking for those changes in the DNA that are reflective of cancer. And the ones that are done without knowledge of an individual person's tumor, those look for common changes across commonly changed genes. And the ones that are done with information coming from somebody's tumor, so the MRD test more typically, those are done with information specifically coming from somebody's tumor. So it helps us really know that what we're looking for is cancer.
And we'll do one more virtual question before handing it off to more live participants. But are you finding mutations in the blood that was not detected in the tissue?
Yes, actually, I think this is one of the really big potentials for it. And I think back to, I keep using the ESR1 mutations as an example, but intentionally so, because they're the most common kind of advanced breast cancer is hormone receptor positive, HER2 negative breast cancer. But those mutations are what we call mutations of resistance, and they really develop in the individual cancer cells around the body when they're in the presence of the treatment that is kind of pushing them to develop a way around the treatment. And we see in an individual person who's been on an aromatase inhibitor or some other kind of anti-hormone directed drugs, many, many different kinds of mutations of those ESR1 mutations, all of which are presumably popping up in different spots of the cancer around the body. And so if we biopsied just one cancer site, we would probably find one or maybe a few, but when we do it from the blood, we see, we can see many, many different ones. And that makes it, I think, more powerful in addition to the other sort of convenience issues, as long as we have the sensitivity for the test.
So my question is, how are you collaborating with the insurance community? So those of us that have these exciting options for us aren't struggling with the pre-authorization, and that's not covered, and that's going to cost you $15,000, and so on and so on. And so actually I had two questions. And are there specialized labs that are needed for these kinds of tests, or can they just go through the labs we go through now?
It's a great question. So the first one, I would say we're in a kind of a funny time for these tests where the companies there are so many of them. There really is a hugely crowded space, the liquid biopsy space. And one of the ways they differentiate themselves is by how easy they make it to order for your physician and for you to have the test. And so they have mostly worked with insurance companies to cover the tests, but in the case of not covering the tests, many companies will eat the cost of the test. And that's fine for right now. I think it will TBD in terms of what will happen over time, and because they can't keep eating the cost of the tests for everybody over time. And so I think it's a little bit of the Wild West right now in terms of all of these different available options and there are ones that we use more commonly than others, and partly because of how easy it is to order the test. But that's a great point and a great question. And now I forget what your second one was. Oh, yes. So these are all specialized. If you were to ask your physician, can we do this test on me? They would probably have, we have here a test. We have the ability. We could order technically any test, but I know I would order one. I can order it through the system, but there's a kit with special tubes that you go to the phlebotomy place to get, and they will draw those and then send them off to the company that does the test. So it's not done at the hospital. Typically, there are some places where they do it in-house, but it's actually because all of the pieces of developing the test are so complex and need specialization that it almost makes more sense to outsource it anyway, from a center perspective. So yeah, they're specialized tests, but they're very common and they make it easy to order, and so it's fairly straightforward. Yes.
Hi there. Thank you for the informative brief. I just got two questions. I guess it's one from the clinician point of view and then one from the patient point of view. But I guess, how is ctDNA used today to treat current patients or to track remission status versus where it's going in the future? And should patients be asking for periodic ctDNA blood work, or is the test still too novel to ask for?
Right, those are great questions. So for the first one, I think and again, because the questions can be so different, we're really focusing in right now on advanced breast cancer for your question about how, whether it's being used and what it can do to change care, is that these are the most important use for these tests right now is really to select a therapy. And so that is, I think, in some ways the most powerful thing we can also have is a test that predicts, resistance or response to treatment. And so that's why I'm using it in clinic. That's why I think most of my colleagues are using it in clinic. And in terms of how often to do it, we usually do it at time of diagnosis and then the time when we're thinking about treatment switch for either, there's clinical signs of need for treatment switch or that sort of setting. But the use case in the future, I think, are many potential use cases in terms of what we could do with it, including using it to, potentially not need to do scans for a very long time because we just can track it in the blood pretty reliably. That would be great. It'd be, hopefully, I think you could imagine a model where it's much cheaper, it's less onerous. People might not have to come into clinic very often if they were otherwise doing well and feeling good on their treatment. And then in terms of whether it should be asked for by a patient, I would say yes, patients with advanced breast cancer should have this. And there's some nuances to this in terms of the subtype. It's most useful right now in hormone receptor positive HER2 negative breast cancer, but I still would order it in other subtypes of cancer. Not all the time, but certainly at diagnosis and again, at the time of disease progression for consideration of treatment selection. And then I think we'll be using it more commonly and more often, but that's a little bit of more, there's not, it's not definite right now.
And it's great to see so many of the questions in person answering the questions that were asked online. You guys are in sync. We'll finish up with the last question, and this is kind of also anticipating the future of ctDNA testing. It will become more and more sensitive as we get better. Are there any current trials for triple-negative breast cancer patients with ctDNA, or do you see those coming up the pipeline?
That is a great question. I think that there are, for triple-negative, I don't know of specific triple-negative breast cancer or advanced breast cancer trials, but patients with triple-negative breast cancer would be eligible for most trials for a targeted therapy that's based on a specific DNA alteration. So I would still encourage people. So somebody with triple-negative breast cancer could have a coming from the cancer PALB2 mutation, or a germline PALB2 mutation, or coming from the cancer BRCA1 or 2 mutation, and those would be very potentially treatable with a targeted therapy, either on or off study. That's just one example, but it's important still for patients with advanced disease.
Wonderful. Well, give it up again. Thank you, Dr. Parsons.
Thank you.
That was amazing. So many questions we were able to fit in. So we had questions about health insurance, and so that's a good segue into our next topic about finances. So I'm pleased to welcome Dr. Christopher Sue, returning from last year, and he's going to talk about financial toxicity. Dr. Sue is an assistant professor in our clinical research division here at Hutch and affiliate investigator at the Hutchinson Institute for Cancer Research Outcomes, or the HICOR. So, Chris, welcome.
Thank you. Hi, thank you, Dr. Lee, for that kind introduction. Good morning, everybody. It's very nice that you are here. So my name is Chris Sue. I am a blood cancer oncologist, but I spend most of my time doing care delivery research. I'm very focused on the financial barriers that patients and caregivers experience during their cancer trajectory, or their time getting treatment for cancer and the subsequent survivorship. I am not a patient with cancer. I do not have a lot of the experiences that many of you here have. My goal is to give an overview of what financial toxicity is, and to sometimes level the playing field a little bit in terms of the understanding that people have about financial difficulties. Some of you here in the audience will know what I'm going to say without me even saying a single word, because you experience it on a day-to-day basis. Others will have no idea, because others have never had to struggle with the having difficulty with payments. So I just kind of aim to give an overview about this, and just to kind of show that we have a big community of physicians and researchers that are actively working on solving these problems. And then I'll try to keep my remarks short, and then later we'll have a team of excellent staff here at the Hutch that can give you some tips about or like resources about what we can do to resolve this issue. And so I'd like to include this picture. This is what I found from the New York Times, the first mention of financial difficulty from 28 years ago. So nothing that I'm saying here is new. We've been struggling with affordable care for a very, very long time. So what is financial toxicity? Financial toxicity is the unintended but not necessarily unanticipated objective financial burden and subjective financial distress experienced by patients with cancer as a result of their treatment. So this is the official definition by scholars, but I like to kind of point out that there's two components. There's the burden that you feel, the dollars and cents that you pay, but then there's also a subjective level, the distress that one might feel, not being able to, afford their care. So there's two components. There's the money that's coming out of the pocket, but there's also a big psychological component. So over the course of my research, I've spoken to hundreds of patients with financial difficulty, and with their permission, I've gotten some very good anecdotes and quotes that I'll share with you over the course of this presentation. So one of the patients here told me, I'm in debt in a reverse mortgage with my home, but I don't use the money. I don't need the money to live on, not at all. It's a hedge to take care of the unexpected costs related to my having cancer because I don't have people, I don't have children. Some people will say, well, my kids will take care of me. Well, I don't have any kids to take care of me. So here's a patient that was so concerned about the cost that she might just suddenly be sprung upon her that she just decided to take out a reverse mortgage on her home, so she has some liquid funds in case there's all these unanticipated costs that will just suddenly come up. So like I said earlier, the most common thing that people think about when they think about financial toxicity is the out-of-pocket drug copayment, or what you pay at the pharmacy, because that's something that's the most tangible. But there's actually a lot of costs. And again, this is a diagram from one of the classical articles that talks about financial toxicity. But I just kind of like to break it down into the various components where you might have difficulty with costs. So first of all is, yes, drug costs. So cancer care is mostly shifting over to the outpatient. The more we can do the care as an outpatient, we try to do it. But then this leads to expensive oral cancer drugs and co-payments. There's a lot of lab testing. There's a lot of office visits. Sometimes there are co-payments associated with that. But more commonly, it's actually the travel, traveling to the lab, coming to the clinic, parking. Every time you come, you're paying for parking, those kind of things. There's other treatment costs, transportation. I talked a little bit about, we have patients coming here from various parts of the state, sometimes coming from other states. When you're traveling such far distances, there's a gas expense, there's a plane travel, there's food, lodging, and then there's also sometimes co-payments for medicines that you need, not necessarily for the cancer itself, but for symptom controls, anti-nausea medication, pain medication, for example. All these costs can, the burden of treatment can add up. And unfortunately, in some patients, it leads to job loss, it leads to lost wages, lost opportunities where they can be earning money. Then this leads to sometimes depletion in savings and assets, patients taking on debt and loans, then leading to loss of credit, and in severe cases, bankruptcy and foreclosure. I spoke a little bit about the psychological impact of care, and a lot of patients will report a lack of productivity, sometimes family tension, hopelessness, suicidal thoughts, hopefully not to that stage, but then, a need for counseling and psychological therapy, which then could potentially lead also, ironically, to more costs and more burden. So very busy slide here from the same paper, but I really like to focus on this, this end portion of this diagram. So we have all these stressors. And then what happens to these stressors? Well, patients develop coping mechanisms. And a lot of the coping mechanisms that patients do is they start borrowing money, they use up their savings. I talked a little bit about this. But then this leads to almost like a negative cycle. You notice at the end, it becomes this endless cycle of like just basically distress, poor quality of life, and then leading to potentially poor outcomes, because then for some, they're no longer attending their appointments regularly. They're starting to skip pills because they can't afford all the medication. And then unfortunately, it just goes into a negative spiral. Another patient here, this was one of the interviews where I felt, very, I felt terrible for their situation, and I was very grateful that he wanted to share with me this. He said, the first 3 years we were dealing with this, we never heated the house. We just had the kids wrap up in blankets, and luckily we're up here in the Pacific Northwest where it doesn't get super cold. There were weeks where it gets down below freezing, and we just had one space heater and heat one room. We would all hang out in that room and play games or watch TV or whatever we could do just to keep warm. So here's somebody who didn't even want to turn on the heat because the heating is too much money. One of the things I like to really point out to both patients, caregivers, but I think more importantly, researchers and physicians, is that financial toxicity can really occur at any point in the cancer care trajectory. So a lot of times, we really just kind of focus on patients getting into our health system and saying, oh, you're a new patient to us. Here's the full suite of services that we provide. Please avail yourself to them. Do you have any of these issues? Well, for a lot of people, they just were diagnosed. And so they haven't had to experience all of the costs that come with it. So they're going to say, no, I don't have any financial problems. And then we're like, well, great. Okay, well, you don't have any financial problems. You don't need anything. Goodbye. But then what ends up happening is that, 1 year later, 2 years later, the financial problem starts happening, but we're not asking them anymore. They come to the doctor and they're, too ashamed, or the oncologist is too busy to ask the patient about their status. And so nobody ever mentions it. The patient is just struggling there by themselves. And then, they start falling off. They start not going to their visits. So we don't want that. We really want to know at various points. We need to be better at figuring out at all these different time points in the trajectory about how we can help, and whether there might be services that patients and caregivers can benefit from. So various studies depending on, obviously, as you can imagine, financial toxicity varies a lot depending on what type of disease you have, what type of cancer you have, and what stage of cancer. But it's pretty consistent across most studies, regardless of what disease we do it in. About 30 to 80% of cancer patients and survivors experience financial toxicity. Around 10 to 20% experience severe financial toxicity. So we know this is an issue. If you are struggling, we want to see how we can help. So I'll briefly cover some helpful resources. I'm not going to go into this in a lot of detail because we have some experts here that will talk right after me. But I usually recommend for patients to use their social worker and patient navigators. We have a bunch of great social workers and patient navigators here. I hope they don't mind me saying that they should like to really avail yourself to their services, they know the most. They know way more than me about what resources are out there. They are the hub to all your resources. But definitely, even at your oncology visits, if this is an issue, please tell your oncologist. Everybody, I will say that I don't think there's a physician that doesn't want to know about this and doesn't want to help you. We all want to help, and we all want to make sure that you're not struggling, because if the less you are struggling, the more likely that you are able to stay on your treatment and get good treatment outcomes. And as I said, financial toxicity is complicated, and the solutions are not one size fits all. I'm going to cover two areas here about drug costs and hospital bills, because I think these are things that are kind of more aligned to what we do, and I'll kind of leave the rest for our colleagues here. So high drug costs. Again, another patient here. I had no idea that a medicine can go from free, meaning a $10 to $20 copay, all of a sudden to $250. They, meaning the pharmaceutical companies and insurance, are setting their own price. I didn't know that they could do stuff like that. My own going through that experience was very frightening. I could die from this cancer because I can't get treatment. So if you have issues with high out-of-pocket drug costs, typically the first step is to really examine your insurance coverage. If there's a way to get some help with this, usually like a third party can look over your insurance and see where the gaps are and whether you might qualify for some better insurance. If you have Medicare, there's really good service here in Washington State. It's called the Health Insurance Benefit Advisor, SHIBA. They're actually volunteers, or maybe they're paid a nominal amount, but they're basically these like Medicare navigators that are often set up in community health fairs, and you actually can also call them. But they basically walk you through various Medicare plans and see if you could get a plan that kind of better aligns to what you're using. Our pharmacists, clinic staff help patients apply for pharmaceutical assistance programs. Usually, they'll let you know if you qualify for one of these programs, but basically you get discounted medicine or free medication from the drug manufacturer. And it typically wants some proof of income or tax returns. There are also cancer center and foundation assistance. So for example, the Patient Advocate Foundation, the Leukemia Lymphoma Society, I'm sure a lot of the breast cancer societies, they have some assistance relief programs. So if that's something that you're not aware of, but you might benefit from, for example, you have a very high out-of-pocket copay for one of your oral pills, might be something to look into or ask at your next clinical appointment. There's also different websites that have drug coupons or discounts. Usually now, I think if you have good insurance coverage, these coupons are not really going to be much cheaper than what you're already paying, but for some, these coupons might actually be helpful. So for hospital bills, one thing that I think I've always been a great payer, I will put my bills before I eat. I will literally go hungry before I will miss a bill. The reason is that if I can't pay my medical bills, then the hospital is not going to treat me. This is a patient that told me that she prioritizes so much in paying all of the bills that the cancer center sends her that she cut down on groceries, she cut down on her life expense because she is so scared that if she misses a single bill, the hospital is going to say, we're going to kick you out, there's no more treatment, goodbye. So I felt terrible that she told me this. If you need help with unaffordable hospital bills, for the people who are making less than 400% of the federal poverty level, I put some income figures there. You can get discounted out of pocket. So any cost that you incur from a hospital or a medical center, you can kind of get discounts for it. If you're making less than 300%, then you should get charity hospital care. There is an application process. The details about these care programs, even though the hospitals are mandated to let you know, are often obscure. They don't tell you right off the front. And the hospitals, importantly, you need to have maximal health insurance that you can be eligible for. So for example, if you are eligible for Medicare or Medicaid, you need to have that already before you are eligible for this level of charity care. So if you do not finish applying for your insurance, you might still get these hospital bills. But for the patients that are literally making very little money, you should not be getting excessive amounts of hospital bills. If you still have a lot of hospital bills, and this kind of applies more generally, if you are getting bills that you cannot pay, while hospitals can send your the standing bills to collection agencies, many are willing to negotiate with you in good faith to talk about what the issues are and to come up with a payment plan that you can afford. So I think the best thing to do if you're getting hospital bills, and I think we have, again, more patient finances here that, I hope I'm not speaking for them too much, but it's really to just, I usually advise patients and caregivers to start a conversation and to really talk to the cancer center and the hospital about the reality. The worst thing that you can do is to just ignore things and to just pretend that things are not happening, because then, sometimes these hospitals or medical centers might escalate their escalate their collection methods. There are also some nonprofit organizations like the Northwest Justice Program. They're a group of lawyers that work pro bono that could kind of look at clarifying your rights if it becomes like a legal issue. They're also very helpful with evictions if you're dealing with evictions or housing difficulties. Do not put any medical bills on credit cards, because usually there's a way to try to resolve these bills. So putting them on credit cards is worse, because then you're starting to accrue interest on these credit card bills if you can't pay them off. So I'm like 1 minute over, but I want to emphasize again, it's never too early or too late to reassess your financial resources and truly understand your current insurance plan in preparation for an earlier, rainier day. So thank you very much. I look forward to your questions in the Q&A. If you want to share any of your experience or talk about anything at all, my email address is there. I really love hearing from patients. Thank you very much for this opportunity.
Thank you so much, Dr. Su. What an amazing golden 15 minutes, and we'll have an opportunity for more questions and answers. Next, I want to bring up members from our patient navigation, social work, accounting, and financial counseling team. So kind of everyone you'd want to talk to, we got them all here together. So thank you again. So this is Anne Devine, Jourdan Cruz, Adrienne Mendoza, and Elaine Chan.
Hi, everyone. Thank you for being here today. My name is Adrienne Mendoza, Patient Account Manager here at Fred Hutch. Joining me is my lead, Patient Account Representative. Elaine Chan was also originally supposed to be here. Unfortunately, she is under the weather, so she can't be here today. But it is a pleasure to be here to speak with you all and represent patient financial services. All right, so I would like to start off with revenue cycle. It's probably a term that you haven't heard very often, but I would like to explain that. Patient Financial Services, or PFS, is just one part of revenue cycle. Patient Financial Services is a team that helps with insurance, billing, and payment options. We're part of a larger department called Revenue Cycle, and this team essentially make sure that everything from registration to billing to final payment runs smoothly for your care. This next slide just highlights just a few of these departments. So there's about over 100 staff members in the revenue cycle department that make sure that everything behind the scenes is handled appropriately so that you can focus on your care. Most importantly, what I want to go over today is just to share about what happens behind the scenes in revenue cycle, but also how you can learn more about what to expect in the billing process, and also how you can access the resources that Fred Hutch has to offer. And that way, sorry about that. Let me go back here. Skipped ahead. All right. Most importantly, how you can make informed decisions about your care. Next up is our financial counseling. Our financial counselors are certified navigators for Washington Health Plan Finder. They are trained to help provide understanding, help with insurance options, complete applications, and help you enroll in these plans. They can connect you with a number of different assistance programs. SHIBA, as Dr. Su mentioned. There's also state Medicaid, as well as Fred Hutch Financial Assistance. With Fred Hutch Financial Assistance, if you're approved, you can potentially receive free or discounted care for your services. If you're approved, these approvals are good for a 6-month date span. Once you hit that expiration date, all you can do is just reapply. Very easy to access. Next is financial clearance before your visit or procedure. We check your insurance and benefits. It's very important that we make sure that everything is taken care of before you receive your care. This can start with eligibility, any referrals that are needed, or authorizations that are required by insurance companies. The process called financial clearance, it really just helps us avoid surprise bills. It helps us ensure that you know what to expect next. It's one way that you can focus on your care and not the paperwork. And estimating costs. This is a very, very important part. It's an important piece because price transparency and estimating costs prior to your procedures or services are important. Healthcare can be expensive, and understanding the costs ahead of time can help you feel a little bit more prepared and less stressed out. That's why we offer estimates before your procedures, so you can plan ahead, you can ask questions, and you can also feel very confident about your financial choices. It's part of how we support you, not just medically, but also financially. Our financial coordinators are specifically here to help you with any questions prior to your services. That way you know what to expect. You don't have to worry about the billing while you go to your appointment or while you're receiving your care. And PFS customer service. This is the customer service team that I proudly manage within the Revenue Cycle Department. We are responsible for answering a high volume of phone calls, messages through my chart that we receive, emails, anything regarding patient billing or insurance. Our goal is to make sure our patients and caregivers have a good understanding of their balance, but also we want to give you guys the options to help resolve that balance. This means we could potentially collect the balance, we could set up a flexible payment plan, or we can connect you with one of our financial counselors. We can screen you for financial assistance during that phone call. We know that getting care can be stressful, so we work hard to make every interaction and as smooth and supportive as possible. Great customer service means you're treated with respect. It means that your questions are answered clearly and that you are taken seriously. It's not just about the care, it's about making sure you're cared for. What sets us apart is how we treat you, not just as a patient, but also as a person. So friendly, helpful service from beginning to end is going to make your experience from start to finish way better. Next, we have our Health Information Management Team, or HIM. And this team is responsible for accurate, confidential, and accessible management of patient health records. At Fred Hutch, our team is divided into 4 different pillars. All of them are focused on quality, consistency, and reliability. So when you understand your health history and have access to your records, you can make better decisions and feel more in control of your health. And that is patient financial services and revenue cycle in a nutshell. Again, it's very many departments. There are over 100 staff in this department who help you and make sure that everything is running smoothly. I know I was short on time and I probably was not able to go into all of the details, but I do have my contact information here. Please reach out. We would love to hear from you, and we are here to support you. Next, I'll hand it off to Jourdan and Anne.
Hi, it's nice to see all of you today, and I'm glad you're here. I was looking around to see if I recognize anyone. I don't think I do, but I have been here 11 years working with patients to help them through navigating this illness. And this is my colleague.
Hi, everybody. I'm Jourdan. I have been here at the Hutch for about 5 years, and I am the social work manager.
So this quote here is from one of our patients that I'll always remember. He said, "I can deal with all the cancer. It's all this other stuff that's driving me crazy." And that's what kept him awake at night. And of course, it included, as Dr. Sue mentioned, travel, parking, medical lodging, food that was more expensive in Seattle than where he lived. And so we were able to help relieve some of his stress, thank goodness. So we've developed this hub and spoke model, or I see my colleague did here. It's really a complex topic when you get into discussing finances because everyone's at a different point. Some of you may be just diagnosed with metastatic disease, others may have been living with it for a long time. You all have different insurance, different resources available to you in terms of support, et cetera. So this is really just a starting point. We are not experts, we are generalists in these things, and we just wanted to put that disclaimer out up front. So the baseline is really important, and I know this is a tedious exercise, but anyone who does financial planning will say, know your baseline. So that means go through all of your bills, all of your statements that you're getting, and simplify by using one account to pay your bills, because many banks now will do the end of month summary and end of year summary for you, so you can really look at that and see where you might be able to cut back on things. There are utility savings programs that you can access if you meet certain criteria. We also are aware of some organizations that will offer a lower expense cell phone, mobile phone, as well as an internet plan, and food assistance, which of course right now we're kind of in limbo here. It is available, is it available? Unfortunately, we're still waiting to find out. One patient did share with me a benefit where you can apply for property tax deduction or deferral, and that really helped her be able to reduce her expenses and keep her home. So we learn a lot from our patients, and we're always open to getting ideas from you.
So this organization in terms of, supports patients and anybody really who is going through cancer treatment for a number of domains of financial literacy. And I learned about them actually from Dr. Sue, and they've partnered with him on a clinical trial that we currently have going on in the immunotherapy team. And they provide these services up here. And I guess, hang on, I'm just making sure my boss isn't in the room before I say anything political. The reason why our cancer treatments put people in debt or put them farther in debt is multifaceted and complicated. But at the base minimum of it is that we don't think you deserve to stay out of poverty to get treatment. As a society, we don't have safety nets that preclude somebody from becoming poor due to their treatment. We have some things that might help at the end when you've already lost your house, when you can't eat. I didn't tell Anne I was doing this. Sorry, Anne.
No, it's okay.
Yes. When you're poor, then there might be some things we can help you with. But we don't stop that train. So Green Path is a wonderful nonprofit that can help you, but they are still a part of the institutionalized way of providing financial services, right? They still get money. You pay them to pay off your debt. So I'll get off this soapbox for a little bit, and then I'll get back on it when Anne is done with her insurance component. But give them a look. They may be helpful, they may not be helpful. I can't guarantee that they will be. But there are institutions who may have a slightly less corporatized look at you.
Thank you, Jourdan. That was good. I think it's, it's the reality, is that it is tough. What we have found, though, is that by putting together several small things, it can make a real difference for patients. And I've helped people who are just blown away when they're first diagnosed. I'm thinking of one person in particular. She didn't know if she would be able to keep working. She didn't know how she would keep her apartment, how she would keep her daughter going to school at the university. And you know what? She did it. You know, we put together resources that she qualified for, got her through some rough spots. And the last time I talked with her, she was looking to go back to work. So people can do it. But the important thing is that you let us know. And I've had people say, I'm so ashamed. I've always paid my bills. I had a good job. And I just say, please, we see this all the time. It's nothing to be ashamed of. This is tough. And the first step really is getting over the shame and just saying, I need help. And then you know what, in the future, when someone asks you for help, you'll say, of course, I'll help you. So those are the kind of the philosophical things that we deal with. And I think that's what Jourdan was providing us. So get some help also from a family member. Keep track of your bills, develop a filing system. And I think what's been mentioned here several times, stay in control of what you can control. And that will help you be better when other things happen that you can't control.
So you all look very good looking and wonderful, and you're not necessarily the people that need to hear all this. The people who make our policies, the people who have decided that your health insurance should be tied to your productivity at work. And if you can't work, then maybe you should lose your health insurance. Right? And we have decided as a society that that's acceptable. Dr. Sue mentioned something that a patient said when talking about high drug costs. They set their own prices. I didn't know they could do that. They can here, but not everywhere. Right? This is a system that we built. Yes, it's a system that's very complex, and deconstructing it would take a lot, but it's not impossible, even though sometimes we feel it is. So on that topic of work, there are a number of agencies that provide both employment and information support as well as legal resources too. Unfortunately, employers are not always compassionate, and they're not always understanding of when somebody needs to take time off for appointments or maybe needs a reduction in their workload. And so these institutions can sometimes help patients go through and even prepare to talk to their HR department, or they have videos on what are their rights as an employee. So Triage Cancer is one of Anne's favorites. I'll let her talk to that. Cancer in Careers has a lot of educational information online. And then one thing that it's not mentioned for everybody when they walk in the hospital, and I think it should be, right? If you can't work, you may be eligible to get your disability from the Social Security Department, right? And what does that mean? This is a program that we all pay into by the taxes that are taken out of your paycheck, right? And it's based on work credits and things like that, but at the end of the day, it may be beneficial for people who are going through treatment. You can still work while you are getting disability payments, but there's a whole heck of a lot of rules, and I'd rather have you get information from people who talk about it and do this every day. So there is a group known as ALSEP, and they're a national organization. They can help you apply for SSDI. They can talk you through the process. They can be advocates through it. And then, of course, in Washington, we have the wonderful benefit of paid family medical leave, at least for the next 3 years or so. But that's another point of challenge, right? Funding these programs. So in Washington, you do have an income replacement program for when you need to be out for the care of yourself or others. And I'll leave it at that, but it is important for everybody to know about it.
Can we go back for a minute?
Yes.
Jourdan mentioned that one of my favorites is Triage Cancer. Actually, all these on this slide are, but Cancer in Careers and Triage Cancer are both organizations that offer a lot of free information. How many are familiar with one or the other? Okay, let's go for it. Triage Cancer was started by some attorneys, and there are a lot of free tools. There are free seminars that deal with the legal and practical aspects of living with cancer and getting your treatment. And they actually have a program where you can get a consultation about your own financial situation. They're not going to sit down and say, invest here, invest there, move money around. They're going to point you to ideas. And so part of what this is developing a strategy for yourself, not just here's a grant, there's a grant type of thing, but an overall strategy on how you're going to deal with this challenge. One patient told me that I referred to Cancer and Careers. Jourdan mentioned that they help with issues related to work. She said, I wish you had sent me this earlier. So that's a really good reference from a patient who found it really helpful. And also is a wonderful organization. Again, you don't pay anything up front. If they obtain your SSDI, they take a certain percentage of your first payment, and that is capped by the Social Security Administration at a certain amount of money. So if you have to make the decision, do I want to do it myself and risk getting denied, or would I rather start out with somebody who knows exactly what they're doing?
I think it's you.
Is it? Okay. I thought this was yours, but that's okay. These are some additional organizations that can help you. Family Reach is a wonderful resource linker. So you can put in your zip code and what you're looking for, and it comes up with a number of options. The Patient Advocacy Foundation can help with co-payments for drugs. And Sense is an organization actually started here based on a research interest of one of our doctors, and they still have a lot of information on their website that helps you just get more information about how to manage your finances when you're in care.
That's it.
And that's it.
Thank you so much. Let's give another round of applause for our team. We are needing some chairs to have a panel, and at this time, the questions from the audience will flow to the front. Yeah.
So I don't know that this is a question so much as a comment, but I've heard from several people going through cancer treatment. First of all, Fred Hutch is wonderful. We're so happy to be here, despite having cancer, but we're happy that Fred Hutch is here doing the work that you're doing, and it gives us a great deal of peace. But my comment is, when you go to My Chart to send a message to your provider, you get a pop-up. And the pop-up has changed over time. It's gotten better. It used to just be like this red flag warning, you know, you may be charged for this question. And it's been softened, and it's now saying, you know, if it takes more than 5 minutes to answer your question, you might be charged. I'd like to recommend that you get rid of that. And if there is a question that requires some amount of payment, just reach out to the patient and say, hey, this is actually going to require a visit or telehealth or a phone call or something. We're going to need to charge you for that. But that pop-up that comes up is a barrier and keeps some patients from asking questions that are really needing to be asked. So that's all.
Thank you for that feedback. It's very important for us to hear that type of feedback because we want to know about barriers and we want to know about how to make a patient experience better and how to make patient satisfaction better. So while Fred Hutch doesn't necessarily bill for that portion. For you, it's important. For you guys as patients, it's important. I will absolutely take that feedback because it's important. Thank you. I appreciate that.
And I'd like to emphasize that Jourdan and I are free, and our staffs are free. We have a large supportive care department, not just us. We have a large supportive care department that includes nutrition, social work, patient navigation, a variety of others. I won't go in. Spiritual health. There's no charge for those particular services.
All right, so I guess a comment and then it's a question related to the comment. To Jourdan's point about, this is the system that we've built, but unfortunately we have to work inside the system that we've built. And so the hardest part, obviously is the physical part that's going through, each patient. But then the secondary part from a caretaker point of view, it's the administrative burden, right? So what I mean by that, it's really the financial part, and this is dealing with the insurance. So, because of the, I have no shame in saying this, because of the prestige factor of what Fred Hutch is. I mean, I thank God for each and every one of you guys. In order to, to continue, the world-class healthcare, that you guys give, I guess the question is, would you guys consider doing something like an administrative support assistant for each individual patient, right? So what that person would do is would take off the load of integrating with the insurance companies, your PCMs, if I have an HMO plan, so from our specialists to PCP to insurance, this is a big, I've spent countless hours on the phone with my insurance company. Luckily, our insurance, they've never denied anything, but I still don't like talking to them, right? And I still don't like talking to the PCPs about, because in all honesty, I mean, and no offense to them, they're just general practitioners, right? They don't understand the level of complexity of cancer, like the doctors, that are in the front row. But I think, and this is, it's obviously probably a 5 to 10 year plan, but would you guys consider doing something like that? Like just how each patient has their own nurse that takes care of the physical side, that family also needs an administrative support assistant to take care of all the administrative burdens that go with this, so we can just focus on the physical side of this in order to get through this.
I will if you don't. Okay. So absolutely. I would want that. I would want a case manager, a patient navigator attached to every care team. And it's an interesting challenge that we have to get somebody to pay for something that doesn't bring in money. And so a lot of our patient navigators actually come from outside funding sources. And then we have to apply to get the institution to take them on operationally. And that is something that Anne endeavors to do, and she's too humble to talk about it. But the amount of grant money she has brought in for that exact purpose is mind-blowing to me, but I'm also a small figure kind of guy. So I agree that I would love for there to be that very particular hand-holding, and I don't mean that in a pejorative sense. I mean that in a literal, well, maybe not literal, don't touch your patients, people. I mean that in a way that absolutely says, we will take care of this with you. Maybe not always for you. You're still gonna have to call the insurance company because they don't like to talk to us either, right? But at the same time, just even knowing that there's somebody who might make that phone call with you, that would be huge, right? So I agree, I'd want that, and I'll put it on Anne's shoulders.
I have a question, and it has to do with how you communicate with the medical team, the care team. When you have to go to outpatient oral drugs, then they usually are third higher level tiers, and your co-pays are the highest. So I sometimes encourage people to try to keep their treatment IV, or in the hospital, or where they have to go to get an infusion because then that's covered by another aspect of their insurance. It's a little bit more difficult for you, maybe, but it's a lot less expensive for you as a patient in terms of out-of-pocket costs. So what I'm wondering is, if I come to you and I'm going through all of this, how do you communicate with my medical team that I need for them to be making their treatment decisions with my financial perspective in mind? Because there are choices always to make in choosing the next treatment plan.
Yeah, I mean, I think from my perspective, I get a lot of, well, one thing, I think I'm pretty in tune with this, so I usually ask the patient. There is a lot of things where you can substitute, like you said, from oral to something infused in the clinic. Like, for example, Medicare, it'll go from Part D to Part B. So then, that takes the out-of-pocket cost off. I actually think that as physicians, we get a lot of messages from usually the pharmacy team where they run through they run the clearances of your drugs, and then they notice that one option is significantly higher than the other one. And so they usually ask me, would I be comfortable with substituting for the other one? And I always say yes. So I actually think there's a lot that goes beyond the scenes. We have a very, very good pharmacy team here. The pharmacists here are great. They are very good at putting in for all those assistance programs that I mentioned, but also finding you the lowest cost. So I think to your question, I think there is a lot of communication that's being communicated, but definitely as a patient, if you notice that there's something that works for you, but nobody is saying anything about it, then definitely raise it to your care team or anybody here. I think people are more than happy to help. But I always try to accommodate the patients to see where they're at. Yeah. And one quick comment while I have the mic. I never bill for my patient messaging. I think that it is not right to do that. There has been these safeguards put in because some patients, unfortunately, are taking advantage of the messaging system and are sending these really complicated messages that should be clinical visits. And so I think most oncologists usually try to turn those into visits if it gets to that degree of complexity. But I fully agree with you. I think it's inhumane to have a pop-up saying you can't ask any questions because you might be charged. So thank you for raising that, because I actually didn't know that pop-up comes up as a provider. I have heard of it coming up, but I actually don't know that they do it here. So I actually think that's something that I think we should get rid of. Yeah.
I just wanted to, first of all, thank you guys so much for, putting this together and bringing this to the forefront and advocating for it over and over and over and over and over, because it's so important. And us as patients, it's embarrassing, right? I mean, to some people. So I guess I have a couple comments. Dr. Sue, the fact that you're a clinician and are focused and interested in this on as far as a patient outcome and how it relates to their health, bravo for you. And thank you so, so, so much.
Thank you very much.
I mean, because your advocacy for your patient health isn't just going beyond their physical and their mental. It's the financial piece is part of our health. So I guess kind of piggybacking off what he said, adding things to the standard part of care. I'm going to sound like I know what I'm talking about, but I don't. Your soap notes, right? I guess they call them that, or they're soaper things, right? Your subjective, your objective, your da-da-da-da-da as you go through your little wah-wah-wah with your patients. Well, it would be great if the medical community could add to that the financial part for you. Because a lot of patients aren't just going to volunteer that. You're going to go through, here's my thing, and here's what I recommend. And, underscoring her point here in the middle, well, this oral chemo drug is great. It's going to be so much more convenient for you. But, financially, it might be better to keep you an infusion because now that's going to be paid, your Medicare, that's going to be paid out of Medicare Part B. So even having your physician open the door, how's your financial health with all of this? A simple question can then open door after door after door and lead them to these teams in a way that's not intimidating for us or embarrassing for us. So to share with your clinical colleagues our financial health when you get into any serious disease is really, really important. So, and the last thing I want to say, and then I'll stop talking, is if anybody has not used ALSUP, this is a total shout out and plug for ALSUP to help with Social Security disability. They are amazing. They are, I mean, they literally did what he was saying. You know, I was linked to them through my employer's long-term disability program. So those are two other things, long-term disability and short-term disability. But they were literally linked, and it was a handoff phone call. I just had to answer some questions. They did absolutely everything. I had to send them some stuff. But, you know, don't discount, you know, what Social Security has to offer. If you think, oh, I don't need that, I don't need that, go there and explore it. And ALSUP they are worth every single penny of what they need for their fee to help. They'll do all of the appeals if you, I mean, I can't say enough about them. So there's my little advertisement. Thank you.
I just wanted to add something about ALSUP. They will help you, like she was mentioning, integrate your work disability with their plan, because there are all these rules and I don't understand them, but they do. Also, Sheba has been mentioned. I've been there to talk with them on behalf of a family member. They're amazing too. I mean, they know Medicare backwards and forwards. There is a spreadsheet on the Medicare website where you can actually go into different companies and see if they cover your drugs or not, or how much they cover. So I would really urge exploring the Medicare website as well. I knew of one family whose the husband was older than the wife. He had his own Medicare Advantage plan, and the copayment for his monthly drugs was $750. The wife transferred him to her insurance for his Medicare Part B. The copay was $5. So it really pays to ask and get information from insurance companies as well ahead of time to see what plan might be best for you.
Thank you. And we have one question from the audience virtually, and then after that we may need to break.
Yeah, so the virtual question is, I was changed to an oral medication that required $2,000 in payment upfront. Was there a resource I could have used to help with this? So thank you very much for this question. I think the $2,000 partly depends on what it is for. Sometimes we're in October, so we're pretty, November today. So we're very late in the year. If the $2,000 is to meet your deductible, then there's probably not that many ways you can get around it, because you have to just put up this amount of money up front to basically meet your deductible for the year. And then after that, you can get cheap or free the zero copayment after that. So I think the question I have for this person is whether it's a deductible or whether it's actually copayment for the drug. If it's copayment for the drug, $2,000 is definitely excessive. So then I would ask the pharmacist that prescribe you, or your care team, the pharmacist on the team, what this payment is for. If it's directly a copayment to the insurance, then I would reach out to the pharmaceutical company and say, I cannot afford $2,000. This is too high. Would I qualify for reduced, like cheap drug or free drug coming directly from the manufacturer, and then basically bypassing the insurance? So that would kind of be my recommendation to address this. I think though it's kind of hard to comment not knowing the $2,000, like what it's being used for and what the insurance plan is. But certainly if this comes up, if somebody's asking you to pay $2,000, do not just pay the $2,000. Please ask questions about what this $2,000 is for. And again, to reiterate the message that we've been honing here over and over again today, we're here to help. So please do not just ever feel like you just have to do everything that somebody tells you to do in silence, because if you have a question, questions are hopefully free, but questions are, they should be free. So it doesn't cost anything to ask you a question. It could save you like thousands of dollars down the road. Thank you.
If you can take one final question.
Sure.
Adrienne, is there a difference between financial assistance and charity care?
They are actually the same. Financial assistance and charity care, they're two terms, but they're the same thing. So when you receive care at a hospital, you can ask for financial assistance or charity care. We know what you're talking about, but it is just one program that we offer. All hospitals offer it throughout Washington State. So if you hear it, if you're confused about, someone says financial assistance, someone says charity care, they are the same thing. And frankly, we try to steer away from the term charity care because it makes people feel, we're offering charity. It's not that. It's really just assistance for your bills. Great question.
Wonderful. Well, thank you again so much. This was amazing. And there are imperfections with the system. I think change begins with an idea that is disseminated through conversation. And you're talking kind of to the right people to hear this. And even if Fred Hutch can't change the whole system in the US, we certainly can try our best to change here. And what I've seen is that sometimes it starts at one center and then, oh, you guys are doing that? Oh, that's great. We should do that too. So hopefully we can start to make some positive steps forward. And speaking of positive steps forward, you're welcome to stand up and walk. We'll begin maybe at 11:05. So next up, we're going to dive into self-care for patients. We're going to begin with nutrition. And it's my pleasure to introduce Dr. Heather Greenlee. She's our director of our integrative medicine program at Fred Hutch. She's a professor in our cancer prevention program in the public health sciences division, a professor in the clinical research division, and professor of medical oncology at UW School of Medicine. So please welcome Dr. Greenlee.
Hello, everybody. Good morning. I'm glad you didn't float away on the way here. So I'm going to talk with you today about food and food as medicine. This is one of my favorite topics. So a lot of women after a breast cancer diagnosis and after a diagnosis of metastatic breast cancer have a lot of questions about what to eat, when to eat, why to eat, how to eat. And there's a lot of confusing information out there. So I'm hoping today to be able to answer some questions, possibly dispel some myths, give you some resources on that you can use going forward, and maybe just to get the conversation started with some folks. So here at Fred Hutch, we take nutrition and food in the cancer survivorship space really seriously, and we have a lot of different things offered here. So first of all, we have nutritional clinical consults for all of our patients. And so I know not everybody is a Fred Hutch patient, but almost all cancer centers have registered dietitians affiliated with them. And so if you're a patient here, you can make use of our excellent nutrition resources here, our dietitians, or if you're getting treatment someplace else, you can ask for a nutrition consult there. I run our integrative medicine program. I'm the medical director of that. And so from an integrative medicine perspective, we talk a lot about food as medicine and food within the larger picture of whole person health. It's one of the really important foundational pieces. We're looking at the whole picture of somebody. I'm going to talk about a website called Cook for Your Life that my research team runs here out of my lab. And that's going to be a lot of the focus today, just to share you some of those resources. And then we do a lot of research in the area of nutrition. Our cancer prevention program here at Fred Hutch is the oldest cancer prevention program in the country. And we do a lot of research focused on nutrition as in the cancer risk area, but we also do a lot of research around nutrition for cancer prevention, cancer survivorship, and just trying to understand, how do we get information into the hands of people who need it. So all of you have probably noticed an uptick of a lot of information out there publicly available about nutrition, whether it be in the cancer space or other spaces. And what we really want everybody to know is where to go to for trustworthy nutrition and cancer resources, because there's really an increasing amount of misinformation and disinformation out there that's confusing to everybody. It's not just confusing to patients, it's confusing to physicians, it's confusing to family members, it's confusing to educators, it's confusing to researchers. And so what we're trying to do is simplify the playing field a little bit and point people in the direction of resources that are really, really solid and trustworthy. So the three resources that we go to are the American Institute for Cancer Research. This is a nonprofit organization that has another arm called the World Cancer Research Fund, and they have a lot of resources on there. They're the organization really internationally that compiles all of the information on nutrition, physical activity, weight management for cancer prevention and cancer survivorship. They're excellent. The American Cancer Society has recently joined with the American Society of Clinical Oncology to provide joint patient-facing information, and so they have excellent information. And then I'm very biased. I think our website is the best, and so this is called cookforyourlife.org, and I'm going to talk with you about that now. So this is our homepage on the website. There's a couple of QR codes if anybody's interested. One of them takes you to the website. It's just cookforyourlife.org. Another one takes you to where you can sign up for our newsletter. We have a newsletter that comes out about every 2 weeks that provides information about the website. And it's a website that's really come out of a labor of love. It was founded by a now 3-time cancer survivor, Ann Ogden Gaffney, when she was a breast cancer patient, and then she later became a bladder cancer survivor. And she found that when she was going through treatment, there was not adequate information out there for cancer survivors on what to eat, how to implement in their lives. So she started a nonprofit organization that blossomed into a wonderful research partnership, and eventually we took over her website here at Fred Hutch when she decided to retire. Our website is offered fully in English and Spanish. We get about 4 million unique users per year across the globe, and we have 1,100 recipes on there, 400 articles on cancer and nutrition, 300 videos, and we also use this as a platform for our research. So please go explore it. It's freely available to anybody. Share this. It's really out there for the community to use. So what I'm going to do today is I'm going to walk you through a little bit to give you an idea of how this might help answer some of your questions. So this is one of the web pages that we have that just shows our recipe finder. And so you can go on there and you can look, you can say what kind of health consideration, maybe you're looking for something for nausea, you can look for a meal, are you looking for a breakfast, are you looking for a main, are you looking for a beverage or a dessert? Do you have any food preferences? You want it to be gluten-free, dairy-free, and then you have preparation, like do you want something quick and easy, cooking for 1 or 2, cooking with a hot plate, and so you can really use that. Usually when you do whatever choices you have in there, you usually get a good selection of recipes. Sometimes it comes up with nothing because there's just too many rabbit holes to go down, but just play around with it and find what you need. But you can see this is kind of what it shows, and then there's different cards that show up with different recipes on there. We have, I call them 3 different pathways on the website. We have one pathway that's really focused on nutrition, food as medicine for cancer prevention, another one to manage the side effects during treatment, and then another page that's focused on nutrition for cancer survivorship. So on the page where we're looking at recipes for the most common treatment side effects, we have information there for low appetite, constipation, diarrhea, difficulty swallowing, early fullness, fatigue, mouth sores, nausea, taste changes. Obviously, not everybody experiences all of these, but we just try to make it an easy way to go and access some of the information. And we purposefully try to make this visually appealing to people because we know when people are feeling crummy, like it helps to have nice color, pretty pictures to get people thinking about, what to eat and how to eat. So I'm going to try to answer some questions right now that are some common questions about symptom management using food. And I'm really just going to skim the surface, but I'm hoping that some of these pointers will be helpful. And then, we'll have a question and answer session later where you can answer more questions. So the first question, a lot of people ask about how can food help me manage nausea? So this is a QR code that goes to one of the articles that we have on how to manage nausea during cancer treatment. These are kind of the kinds of articles that we have up there. But I just want to talk about some of the tips and tricks that we've learned from our dietitians and from our patients over time. So the first thing is to really use small, frequent meals, and that can just help over, help control nausea over time. The other thing is, a lot of patients come see me in integrative medicine and they don't want to use their anti-nausea medications. And they say, I want to do things naturally, I don't want to use medication. And we say, well, some of those meds are some of the most effective ways that we have to manage nausea. And so we really encourage people to get ahead of the nausea and to prevent the nausea from happening in the first place. And so we really encourage people to use those medications if they've been prescribed. And then we can use nutrition to help support that as well. Nutritional approaches to nausea probably are not going to be as strong as those medications that are highly effective. So other things to do are to follow, eat bland foods, use ginger tea. I learned recently that cool foods, not hot foods, actually can help nausea because they aren't as activating for the GI symptom. And just a couple things from an integrative medicine perspective, like smelling an orange or orange flavored aromatherapy can help with nausea. And then something else we do in integrative medicine is we use acupressure. There's some really simple points to push on the wrist that can be helpful as well. Or you can use C-bands to help those points, or you could try acupuncture. So there's a lot of different things with nausea. We really want to eradicate nausea as much as possible, and there's a lot of different approaches out there. Okay, next, how can I use food to manage taste changes? A lot of times when patients are going through treatment, taste changes do happen because of the different treatments. So one of the things that we think about in a food as medicine perspective are all of the different flavors or the tastes. You have sweet, salty, sour, and bitter, but there's a fifth one called umami that really is the idea of umami is that this is this, it amplifies flavors and it's something that makes things more savory. And so these are the tastes, if you think of aged cheeses, mushrooms, tomatoes, soy sauce, fermented foods, it just gives taste this little kind of stronger savory taste. And so when people are experiencing taste changes, adding in those umami flavors can actually really help override some of the taste changes. Other things are to use tart, acidic flavors like lemons, soy sauces, or lemons, limes, vinegars, oranges, pickled foods. And, I frequently hear from patients, drinking water doesn't taste right anymore. And so we talk about adding oranges or mint or lemons to the water to just really try to change the flavor profile of those things. And one of the things to really pay attention, both for nausea and for taste changes, is we don't want people to lose weight because they're starting to decrease food intake, the amount of food that people are eating if they're experiencing these. And so that's really where we bring the dietitians in. If these different symptoms are causing people to reduce the amount of food that they're eating during treatment, we bring the heavy hitters in to be able to help do a deep dive on patients' diets to help figure that out. The last thing is to think about fatigue. And so for cancer-related fatigue, which happens a lot, we really have to think about, our protein, our total calorie requirements being met, are people getting enough protein, are people hydrated, and are people getting enough sleep? So what we generally say is in integrative medicine, we get to talk about all the fun stuff, and we can be very broad. It's the dietitians who will go and give you a specific protein goal or a specific calorie goal. But we generally say eating protein at every meal is really important. Following a healthy diet with plenty of whole grains, eating healthy carbohydrates. I'll say in general, we do not advocate for ketogenic diets that are very popular out on some social media platforms. And getting enough fruit and vegetables to really having a whole, really healthy, balanced diet. Limiting caffeine is important because that can really disrupt sleep, and people think that it's going to give them some energy, but it actually can be depleting over time. And then just making sure that people get enough sleep is important. Oh, healthy fats too. It's important to get healthy fats. So again, these are just sort of high-level recommendations. But now we get a lot of questions about nutrition, and people want to know, what they should eat, when they should eat. So a big question that we get is, do I need to eat organic? And our answer is no. It's great to eat organic if you can afford it. It's great to eat organic if you can find these foods. But the most important thing is to eat fruits and vegetables. When we look at all of our health studies in terms of cancer prevention or cancer survivorship, it's just showing that the more plants people eat, the better off they are. And so we don't want some people we find will restrict themselves from not eating fruits and vegetables because they're not organic, and we are trying to dispel that myth, because it's great to do it if people can afford it and can find it, but it's just the most important to do is to get those fruits and vegetables in, because that's where all of the phytonutrient compounds are in the foods that can be really helpful. The next question that we get all the time is, does sugar cause cancer? If you read online, a lot of people are going to say yes. We firmly say no. This is based on our basic science, our clinical science, our observational studies. And we know that sugar is a naturally occurring substance in a lot of fruits, a lot of starchy vegetables, and it's important to have those be a part of somebody's diet. Now, we don't advocate eating a lot of junk food or highly processed food or food with a lot of empty calories, but a lot of time that we see people having some fear of foods, and we want to just, again, we want to dispel those myths, and we want people to feel comfortable about what they can eat and don't feel that they have to be restrictive. And then the last point is about protein. Protein is really popular right now on a lot of social media, to the point that things like Greek yogurt is hard to buy in some of the grocery stores because so many people are trying to eat so much protein. And if you have any teenagers in your lives, that's like all over there. They have a lot of ideas about protein, even if their mother is trained in this. I will say. So what we want to make sure is that, again, the idea is that protein at every meal is really important. It's important for people to be able to maintain their muscle mass as we go through different stages of treatment. And protein is the way to do that, in addition to regular physical activity. And so if anybody has questions about how much protein to include in their diet, that's where really going to the dietitians is important. But what they want me to say is make sure that we get protein in, every meal. And so that's, breakfast, lunch, dinner, snacks. And there's, a lot of different sources of protein, like, nuts and seeds and hummus and, in addition to animal-based proteins, there's ways to have those on the go and ready to go. So take-home message here. Fred Hutch provides multiple nutrition-related resources for our patients, and most cancer centers do too. We really like ours. We promote an evidence-based food-first approach to nutrition along with a healthy lifestyle. I didn't talk about creatine or any of the protein powders out there. We really think it's more important to eat whole food-based protein as opposed to supplementing with protein powders. Cook for Your Life is a readily accessible resource for anyone across the globe, and we think that people should eat a lot of plants. So thank you very much. This is how to sign up for our newsletter if you didn't get it for the first time. Here are the resources for AICR and the American Cancer Society, and those, please let me know if you have any questions. And I think, is Dr. Hunter here? If not, maybe I get to answer more questions.
Yeah, take your time.
Yeah? Okay, great. Questions, yes? Oh.
Yeah, so people online. Thank you.
How about red meat? So there's, especially
Thank
with
you for
protein, I've been
asking.
suggesting.
Yes.
So my dietitian said I should eat a lot of protein, and so red meat is illogical, but yeah.
And so what did the dietitian say about red meat?
She wanted me to do organic.
Oh.
Like, so, yeah, so if we can afford it.
Is this one of
So-
our dietitians here?
No, actually,
Oh,
it was
okay.
hard to get in with your team. So I use your integrative medicine team, excuse me, but they said for the dietitian, keep your own because it's just, you're in high demand.
Yeah. So, so thank you for asking this question. So if we go to the American Institute for Cancer Research guidelines, which I'm going to actually show here on this slide because I have a little bit more time. These are the recommendations for cancer survivorship and for cancer prevention. And so I'm going to go through these so it gets to your question. The first one, and not everybody can do all this, it really depends on where people are along the cancer survivorship continuum. But the first thing is, if possible, to establish and maintain a healthy weight. We think that that's, we have good reason to believe that that's important. The second thing that, hopefully Dr. Hunter's going to make it in this morning, is to be physically active. If there's one thing that we can ask all of our patients to do, is to move their bodies on a regular basis. It's just not our patients, it's everybody across the board. And the guidelines for cancer survivors are 150 minutes a week, up to 300 minutes a week. And that's of moderate to vigorous physical activity where your heart rate gets up a little bit and you get a little bit sweaty if possible. And doing strength training twice a week to keep up that muscle mass, if people are able to do it. It depends on where people are. The next thing is to eat a diet rich in whole grains, vegetables, fruit, and beans. The next is to limit consumption, and that's so you get all of those phytonutrients, you get all of the fiber. People have probably heard a lot about the microbiome. The way we feed our microbiome is through fiber and through plants, and so you want to get a lot of that in our diets. Limiting consumption of fast foods and other processed foods high in fat, starches, or sugars, and so that's getting out just all of the junk food and eating, whole food, we call it a plant-focused diet. We don't advocate for vegetarian or vegan. But we do want people to eat a lot of plants. So then it comes to your next question, limiting consumption of red and processed meat. And the reason for that is we just haven't seen a lot of health benefits of red meat. There are some concerns that there's some aspects of it that can have poor health outcomes associated with it, but it's going to depend on somebody's individual situation. So we really suggest lean meats, fish, so chicken, fish, those animal proteins as much as possible. Eating some red meat in moderation is fine, but we really think that, when we're looking at the health benefits of dietary patterns, that's what we see. So, and again, the organic piece, yes, that's great if people can afford organic red meat, but it's really expensive, and a lot of people can't afford that, too.
Just can you define some?
Well, yeah, I mean, I think if our dietitians were here, they'd probably say once a month kind of thing. So, yeah. So maybe, and also looking at portion sizes too, and so smaller. And if you look at, other cultures around the world, a lot of times they use red meat as more of a flavoring on top of, instead of eating, a gigantic steak. So, really thinking about it that way. But obviously there's some disagreements out there. And so this is why we're pretty conservative here. We're working with cancer patients. We want to make sure that the information that we give people is really solid. But I think that's also why working with somebody's own dietitian, if somebody's anemic, there might be reasons to do red meat there. If that's the only protein source that they can get in, if that's just the easy way to do it, sometimes that's more important, and that overrides these other recommendations too. I'm just going to finish going around my circle here. So then the other one is limiting consumption of sugar-sweetened drinks. And so that's important. Limiting alcohol consumption. So we haven't talked about alcohol. Alcohol is a carcinogen. The recommendations now for cancer survivors are no more than 1 serving of alcohol per day. And there's a lot of cultural reasons that people drink more than that, but that's the general recommendation that's coming out now too. And not using dietary supplements for cancer prevention. We talk a lot about that, or for cancer control. Again, we look about getting nutrients from food instead of from supplements. And okay, that's it. So thanks. Yeah.
So what is your opinion on fasting, prolonged fasting and intermittent fasting?
Yeah. So good question. So we have a lot of interest in that area, and one of the concerns that we have, I'll say there's some really interesting research coming out that's not definitive, and it's not definitive across all types of cancer. But one of the concerns that we have is when people are doing prolonged fasting, that they're losing a lot of muscle mass. And if people are losing a lot of muscle mass, that can be associated with poor clinical outcomes going forward. And so we really need to make sure that people are getting enough calories in. Our general recommendation is we're usually fine with overnight fasts of like 13 hours. That's just a prolonged fast overnight. But multi-day fasts, sometimes we're really concerned that patients are losing weight and losing too much muscle mass. But again, that's where talking to a dietitian about somebody's specific situation can be really, really useful. And there are some great studies that are ongoing right now. Most of the studies have been animal model studies, and those results don't always translate to people.
It's sometimes hard to get protein through foods.
Mm-hmm.
What do you think of using the supplement powders?
Yeah, so again, I think that depends on the person. And so we have some information on our website about good protein supplement, like shakes and things like that. And so that can be useful. And our dietitians have a really good list of those. And I think it really, and that's where we have to be really clear, like what's the daily protein goal so that we can make sure that patients are getting the right form of protein. One of the problems with a lot of proteins powders is that there's a lot of other junk that's added to those protein powders. And so we want to make sure that those are really clean sources. If you don't understand what some of the ingredients are on the label, you might not want that in your protein powder.
In terms of food as medicine, I think I totally agree with you. And but you didn't mention like how you cook the herbs and using turmeric, curcumin, and a lot of these things that have been shown to have beneficial effects for our health system.
Yeah. Thank you for asking that question. So we think cooking is really important. And so one of the tenets that we have is, suggesting when people can cook at home, that's the best because there's going to be less junk in the food. Usually if people cook at home, it's going to be familiar and it's usually going to be healthier. We actually do a lot of culinary education in my research lab where we are testing to understand what are the ways that we can best deliver culinary education for cancer survivors. And so we talk a lot about using familiar herbs and spices so that they like the foods, but then there are also some medicinal values of some of those. Now, turmeric, I'm glad you mentioned turmeric, because if you read online, turmeric will cure all of our health, everything, but we haven't found that to be true yet. And we actually have some concerns about taking turmeric supplements because it can interact with treatment. And in some cases, actually, when we think about breast cancer, some forms, we're concerned that turmeric can actually act as an estrogen. And so we dissuade our patients from using turmeric dietary supplements. However, cooking with it as an herb or a spice, that's fine. And we think that that's important and good to do. It has really wonderful antioxidant and anti-inflammatory benefits. So we do, so in terms of, cooking with herbs and stuff, we do have some information on our website about that too. Thank you for that question. Hi.
Which is somewhat related to my question regarding soy products. And I don't know what the right term, estrogen related. How?
Yeah, so soy is fine. For a long time, there was some concern that soy is considered a phytoestrogen, so it's a plant-based estrogen. And there's a lot of concern that that was going to turn on breast cancer cells specifically. And studies have shown that it's totally safe and it actually can be protective in some cases. And so what we say there is soy in moderation. And so eating a little bit of soy every day is fine.
And this is not really related to cancer, but why is that phytoestrogen? I read sometimes about how we shouldn't overfeed a growing child with soy products because of the phytoestrogen?
So actually for girls, we actually have seen that, eating soy and eating phytoestrogens, especially during the pubertal window when girls are developing, that can be protective against breast cancer risk. So I think we like soy and we like phytoestrogens, yeah.
That's the soybean. Just a question on preparing food. So either to dispel rumors or maybe it is in fact true, with cooking foods like either grill or, on an open pan, like, what's the carcinogenic rate of, let's say like over open flame versus not? I mean, I've, heard things like, hey, it can cause, it may not. I mean, does it matter? I mean, is it something like, hey, just don't grill out your food anymore, but just stick with it, oven baking, but what's the science saying?
Yeah. So I think it was one of the local TV stations asked me that question. I was on TV this summer answering that exact question, which was kind of funny. And I wasn't anticipating that. But so first of all, when you grill vegetables, you don't have to worry about polycyclic aromatic hydrocarbons. So grill your vegetables. Grilled broccoli is amazing. When you grill meats, you do. And so there is an association with increased cancer risk with eating a lot of those meats. And what we recommend is baking meats instead of barbecuing them, because then you don't have that same chard that happens. So that is real. And then the next question is, well, how much, how often, and that's where doing things in moderation we think is important. And I think most of the research is more on the primary cancer risk, cancer prevention side. I actually haven't seen as much research on that in the cancer survivorship side. And again, so moderation is key. But really do try barbecued broccoli if you haven't tried it. Yeah.
Hi. How much research is being done on foods that interfere with the efficacy of certain cancer medications? Like, for instance, Verzenio, you don't want to do the grapefruit. And there were some small studies done at Scripps that said that soy and some other foods interfere with the efficacy of letrozole. I have seen no, other than that, I've seen it nowhere. And are there any studies examining that?
So I'll say for the first, we know that grapefruit juice, though it is delicious, it really does mess with the metabolism of a lot of different drugs. And so if anybody is a regular grapefruit, and again, an occasional grapefruit, an occasional glass of grapefruit juice is not a problem. But if our pharmacists, we have 2 integrative medicine pharmacists who work with us, and it really is important to make sure that there's no interaction there if people are doing that. I actually haven't heard about the aromatase inhibitor, and you said soy-based foods, and so I'll look.
Soy.
Yeah, I haven't. I will look into that. So I don't think we're doing that research here, but I would. I think that's a question to go ask your pharmacist. So what we do, or because the pharmacy team would be able to explain and be able to evaluate those studies to see, is this if this is just in a petri dish or in an animal model, that's really a different level of evidence than if it's human trials. What we do here with our integrative medicine program is, our integrative medicine pharmacists are available to everybody in the cancer center, not just people within our patients seeing us. Our pharmacists will do a really thorough review of supplements for interactions, and they'll rank them, say like, these ones are fine, these ones might be a little bit problematic, be cautious, look for these symptoms, and these ones, are really contraindicated for different reasons.
We have some questions from the virtual audience I'd like to go through. First, are eggs a preferred source of protein?
Eggs are a great source of protein if you don't have really high cholesterol. Yeah.
Great. And then there was a question about any tips or recipes for patients dealing with a loss of sense of taste. I think the website has a page exactly for this.
Yeah, this is, I would go to, where's our page? Yeah, so really looking at foods to manage taste changes. So we have a couple of articles on that. And then again, we have on the website, if you go here to the panel that was looking specifically at side effects of treatment, we have recipes, a whole panel of recipes looking at taste changes. And not everybody's taste changes are the same, so you just need to play around with it.
And then a really good question from Renee. We speak to increased cancer risk with certain foods, but most of us here already have cancer. Mm-hmm. So is it increasing our risk of growing the cancer we already have?
It depends on the food. That's a very good question. And so I think it depends. And so that's what I was saying. Like the question about grilling meats, I'm not sure about, we have to think about risk of secondary cancers and of other cancers. But I think in general, it's we don't have as precise of recommendations, which is tricky in the metastatic setting. And we're trying to answer some of those questions.
Another participant loves pomegranate. Is that bad? Because they were told something about grapefruit.
I don't know the biochemistry of pomegranates. I would talk to the pharmacist about that. Pomegranates are very different plants from grapefruit, so they would act in a different pathway. Nothing comes to mind, but I haven't looked at that specifically.
Okay. Is taking collagen bad?
We don't really know that much about collagen, and there's a lot of people making a lot of money about collagen right now, similar to creatine is what I do know. And so I think you have to look at what is in the collagen. There's, you can get all of these bone broths and, there's a lot of marketing hype. So anytime there's a big marketing hype push, I have a lot of concern about it. And so I think that's a really good question to ask your dietitian or ask your oncology team, but because it really depends on somebody's specific question. Teenagers are also very excited about collagen. So.
Sure, we have one more audience question.
Yeah.
Yeah. Hi. You mentioned that cooking at home is the best, and which I agree with. I wanted to know what your recommendations are for the pots and pans and utensils that people should use for preparation.
Yeah, thanks. That's a good question. So in general, we recommend cooking with non-reactive pots and pans. So things where any residual of whatever the pot or pan or utensil isn't going to end up in the food. So those are things like any stainless steel, glass, wood. It's just a plant. It'll give you some more fiber. But yeah, so those kind of things. So we recommend in generally, not cooking with a lot of plastics. And again, it kind of depends. And, the Teflon coated pans, I think some studies have shown that if any of that is scraped, that some of that can leach into the food. It's going to take a lot of usage for that to happen. But if people have the ability to use, metal or glass or wood, that's what we would prefer. Yep. Good question.
Wonderful. And with that, talking about lots of food, we're going to get ready for lunch. Let's give another round of applause for Dr. Greenlee.
Thank you. And I'm sorry you missed Dr. Hunter, but I'm glad I got a chance to talk with you more. So.
Yeah, and just this, because we are about to resume, and we're going to start off with Dr. Hanna Hunter, who's going to continue our theme of patient self-care. And we talked about nutrition. Now we're going to talk about exercise and building resilience. So as we welcome Dr. Hunter, she's our medical director of cancer rehabilitation in our rehabilitation division in Fred Hutch. And she's an assistant professor in the Department of Rehabilitation Medicine at the University of Washington School of Medicine. So let's welcome Dr. Hunter.
Thanks, everyone. I'm sure everyone got some great information by Dr. Greenlee about how food is medicine. I would say the partner to that is that exercise is also medicine. I think of nutrition and food as kind of the substrate. If we think of this as like a chemical reaction, if you go back to chemistry, you need substrate for a chemical reaction to happen, which are the components. But the stimulus to grow muscle or to improve function is physical activity and exercise. And while we know there's benefits to physical activity, I'll talk a little bit about the cancer-specific benefits. Beyond just building muscle or getting stronger, what we're learning more about physical activity as a component that actually builds our physical resilience. And I'll start by sharing the physics definition of what resilience is. It's the ability of an elastic material, such as rubber, to absorb energy and release that energy as it springs back to its original shape. So if we think about this as a parallel in medicine, our goal as rehab experts is to help patients in terms of enabling you with tools to be able to bounce back from any stressors. And that can be cancer itself, surgery, radiation, treatment. Because while we know those things are important for cancer-directed care, we also want patients to feel like they can physically do the things that they want to do and need to do to remain their level of independence and physical functioning. And when we think about resilience in the medical sense, it's this ability to maintain psychological and physical functioning in the face of stressors. And so rather than reacting to someone being weaker or losing function, we want to be as proactive as possible to build that resilience. And so I specifically study this idea of rehab prior to a stressor, and we call this prehabilitation. And this has been gaining popularity because it kind of makes sense. Why don't we try to build individuals up before something like surgery or changes in treatment may happen? We want to build that foundation so that you can bounce back quicker. and this is kind of the thought process behind it, so kind of follow with me here. So we know that as we get older, we have a decline or a decrease in our muscle mass and overall strength with general aging. But in the setting of cancer, that slope of decline may be a little bit faster because of all these different stressors that your body may face, whether it's due to cancer itself or different treatments such as surgery or chemotherapy. And the trajectory of decreased strength or decreased function may be more dramatic than someone else of the same age. But with prehab, if we try to promote more physical resilience, to withstand those stressors, maybe we can get the slope of patients' function and overall independence to actually be closer to that of someone without cancer, along the slope of general or normal aging, let's say, in recovery and survivorship. And this has gained a lot of popularity, as you can see in this graph in green. This is the number of studies of prehabilitation and cancer over time. And this was not really studied, let's say, a few decades ago, but really gained a lot of popularity recently in say, the last few years. Because again, we've noticed or we learned that that exercise not only improves strength and function, but has the potential to help patients tolerate treatment more, so decrease maybe severity of adverse events, as well as improve their quality of life during treatment and survivorship. I'll share this is, again, a fairly new idea, because pre-World War II, doctors were prescribing bed rest, whether you had the flu, whether you had major surgery, and it wasn't until World War II where there was something called the baby boom, and the hospital wards were full of women in labor and delivery, and there were not enough beds. And they were noticing that the individuals who didn't have beds, who were walking around, had decreased rates of blood clots, infections, were actually healing faster than the ones who were prescribed bed rest. And that really started this field of rehabilitation medicine. So thanks to all those women. And from then on, we've been able to learn all the benefits of physical activity, to the point where in 2022, finally, we have a guideline from the American Society of Clinical Oncology that simply states, it's going to be novel, oncology providers should recommend aerobic and resistance exercise during active treatment to mitigate side effects of cancer treatment. Not to get stronger, but specifically to mitigate side effects of cancer treatment, and this is huge. And so now when we study physical activity and exercise for patients with cancer, it's not just for bone or brain health or cardiac health, we know that. We're trying to study how this is helping patients during cancer treatment better tolerate their treatment and bounce back. And so with all the physical activity studies that have been done, the American College of Sports Medicine has been able to compile all of these studies, and we've been able to show that physical activity can improve fatigue, sleep, mood, quality of life, as well as bone health, heart health, brain health, and specific to, or not just specific, but important in breast cancer patients is for lymphedema. We also used to tell patients with lymphedema, don't move the arm that's swollen, but now we know that physical activity can actually be helpful to prevent and decrease the severity of lymphedema. The general recommendations for physical activity and exercise, I think Dr. Greenlee mentioned this prior, is actually no different than the general population. Same as the American Heart Association guidelines, same guidelines for cancer survivors. At least 150 minutes of moderate intensity aerobic activity, which we'll talk about what that means, and resistance training twice a week. But that doesn't mean everyone has to go out and hit this 150-minute goal if you have side effects of treatment like pain, fatigue, neurologic side effects of treatment. Exercise prescriptions need to be personalized. We have to figure out which movements are going to give you the best bang for your buck, just like an athlete who's trying to run faster, jump higher, it's not just about hitting that minute target or a step count goal. We really want to figure out, and which is what our rehab team does, figure out which movements, what type of exercise, how intense it should be, how frequent, that's going to help you reap those benefits. An important strategy is pacing. I think of pacing as being energy-wise. We can all be motivated to go out and do some physical activity, but we do need a strategy, especially for patients undergoing treatment, that we don't want to empty the entire gas tank of energy that you have going on a walk or doing an exercise for the first time. We highly recommend that if you're starting a physical activity routine, to discuss with your team or potentially get connected with a rehab expert to figure out that dose, intensity, frequency, type of exercise, and such. And so when we think about pacing in terms of figuring out a physical activity routine over time, our goal is to help patients find their new baseline, not what physical activity you did 2, 5, 10 years ago. Figure out your energy levels now, figure out what you can tolerate, and then increase slowly. Even for athletes who are coming back from an injury, we tell them they're allowed to increase their intensity or duration of exercise by 10% a week. So I'll do walking as an example, but walking does not have to be the sole form of exercise. But if you're going for a walk and you walked half a mile, if you walk a mile the next day, you actually doubled your activity by 100%. That is nowhere near 10%. So I tell patients, think about adding a few houses, adding a block, but do not feel like you have to exponentially increase your step count goal or physical activity just to hit that 150-minute goal. Figure out what's right for you now and incrementally go in a safe way that's appropriate. And we'll talk a little bit more about that too. There's all these fancy ways to gauge cardiovascular health and exertion. But in our exercise studies, we've learned that patients or individuals are really good gauges of their own exertion. We call this the RPE, the rate of perceived exertion. And moderate intensity exercise is around a 6. So when we say 150 minutes of moderate intensity exercise is a goal per week, that's exercise where your heart rate is elevated, but you're still able to carry a conversation. So we're not talking huffing and puffing, dripping and sweat exercise. If you're on a brisk walk and you can carry a conversation on your phone, you're actually at that moderate intensity goal. I think with fitness classes and just fitness culture, we've somehow only perceive exercise as this max 10 out of 10 effort. But there's plenty of benefit to physical activity where your heart rate's slightly elevated, but you're still able to speak in full sentences. Below that, I would say there's still benefits to low intensity exercise. Let's say you're on a stroll. If you're able to sing a song, usually I'll say you're at the 1 to 3 range. But ideally, if you're able to sing a song, maybe you can up the pace a little bit to get to that moderate intensity activity. The strategy I have when it comes to strength training, I often recommend this idea of exercise snacks. If you're experiencing fatigue or other side effects of treatment where 20 minutes of resistance training is a lot, you're allowed to break that up throughout the day. We'll take a note from bodybuilders who sometimes lift something like 5 times and that's all they'll do. But that's how they grow muscle. They do something challenging for a really short amount of repetitions, and that's okay to do in the morning, once in the afternoon, and once in the evening. You don't have to do it all together. It's basically sprinkling in these exercise snacks or interval training throughout the day to reap that benefit of building muscle. My favorite exercise is practicing how you get in and out of a chair or in and out of bed. For individuals who are ambulatory, we usually call that a sit to stand. Even for individuals who are using adaptive devices for mobility, whether it's a wheelchair or a walker, practicing that transfer is often some of the hardest
or more challenging physical activity functions that they're doing throughout the day. So that's what we want to practice to maintain that muscle health. And in terms of finding a baseline, again, rather than jumping from half a mile to a full mile, we want to avoid this seesawing of overexertion and rest. And so if we look at this like curvy line, a lot of individuals are more than motivated to engage in physical activity, but then they find that they do too much and then they need 3 to 4 days to recover because they overexerted. So I always commend individuals on their motivation, but a lot of times we have to scale back so that you can actually move forward and build muscle or build endurance over time, rather than doing too much, experiencing an injury or having worsening fatigue and then seesawing between overexertion and rest. And I'll end with just a few strategies and some myth busting. Some known strategies to improve your routine of engaging in physical activity is to pair exercise with things that you enjoy. For me, it would be meals. So if you're establishing a routine of sit to stands, I ask patients, do your sit to stand, do 5 with breakfast, 5 with lunch, 5 at dinner. At the end of the day, you've done 15 sit to stands. You can also pair exercise with listening to music or talking to someone that you enjoy talking to. There's also shown benefit to use different activity trackers, whether it's a device, something on your smartphone, or a physical diary, as well as connecting with individuals, like going on a walk together. With physical activity, finding that baseline is hard. And sometimes you'll find that you're a little bit more sore than you want to be, you're a bit more fatigued, and it's totally okay to scale back, find that routine in order to move forward rather than seesawing. And to end, just a few myth-busting things. I know we've talked about this already, but we previously used to tell patients with lymphedema to avoid using that arm, but now there's more and more evidence that strength training and using a limb with lymphedema, particularly in a compression garment, is actually helpful. There's a huge trend now with weighted vests and jumping for osteoporosis prevention or just bone health. You don't need to buy a $100 weighted vest or jump to improve your bone health. Even doing squats or contracting your muscles, doing weight-bearing exercise, even walking, the idea of the muscles contracting, pulling on the bone that it's connected to, that's what's improving your bone health. You don't need dynamic loading to improve bone health. We're learning more and more that exercise is beneficial rather than harmful. Even when you're undergoing systemic treatment like chemotherapy or radiation, you don't have to hold on activity because your body's going through these things. And exercise, like I said, you do not have to be huffing and puffing, flipping tires to call it exercise. There are numerous benefits to mind-body practices, chair yoga, qigong, tai chi, where you are getting a better sense of what your body's doing in a helpful way in terms of low-impact exercise that's beneficial. And even if it's hard to find a routine, there are a multitude of benefits of exercising in the moment that reaps benefit. So individuals think I have to start exercising 5 times a week. Even if you have 1 day a week where you start moving more, there are shown immediate benefits to that on sleep, your mood that day, related to endorphins. So when you can, move a bit more is the takeaway. Thank you.
Thank you very much, Dr. Hunter. Do we have questions in the audience?
Dr. Hunter, are there any community programs for exercise for cancer patients? In my community, I had the Livestrong program, and I like it because it was free.
Mm-hmm. A great question. The Livestrong programs, if you have access to them, are wonderful, often at a YMCA. Some of the virtual program that's great is through Cancer Lifeline. They have different mind-body practices, yoga that are via Zoom. The other option that I really advocate for that's Pacific Northwest based is Team Survivor Northwest that offers virtual and in-person programming as well as a kind of a physical activity retreat where women who are going through or who have completed cancer treatment get together on Bainbridge Island and engage in different forms of physical activity, but also reap the benefits of that community network. So Team Survivor Northwest, Cancer Lifeline, and also the Live Strong programs.
So I don't know if this is a question or a rant or a rave. It can be both. I just feel like exercise is, well, obviously so important with cancer treatment. And it surprises me that it's not more integrated. And I'm surprised when we sit down in front of our medical team and they're like, you know, are you afraid of falling? Are you this? Are you that? And nobody says, like, are you moving your body? And you know, and also if they were to say, let's say I happen to be an avid exercise person, but let's say I know I can't even get to the mailbox. Well, what if they said, well, you could, maybe let's just try to get to the mailbox and next time we'll check in, like, could you go twice to the mailbox in a day or something? So I just feel like, I'm just wondering when it's going to be part of the conversation. And yes, you can ask for physical therapy and get physical therapy, but you already have to have that mindset. It's not integrated in. And I love Fred Hutch and I love everything you guys do, but it just surprises me that it's not part of the conversation. I agree. Thank you. My friend agrees.
I would say, I agree too. I think there's an overall general hopefully push to continue to ask more questions about physical function during healthcare appointments. There are studies that show that patients will be more inclined to engage in exercise and physical activity if they're counseled by their primary oncologist, more so than a rehab doc, because it's probably what I do at every visit. And that's key, that someone's even asking patients about, do you feel safe going to your mailbox? Can you do the zippers or button your own buttons if you're experiencing neuropathy? Really function-based questions is what we advocate for. There's also a push that is happening here, but as well as other cancer centers and healthcare in general, is this idea of exercise as a vital sign. We take your heart rate, we take your blood pressure, but it's also really important to ask about physical activity and not just falls. Like, yes, we don't want people to fall, but we want to know, has your physical activity changed, and has it changed because of X and Y? So it's, again, not just to reach a 150-minute exercise target, but understand what you're experiencing that's limiting your ability to shower on your own, drive, get dressed. And so hopefully we'll see exercise being part of this vital sign kind of taking.
I want to underscore that whole conversation we just had, and I think I mentioned this last year, but for the Fred Hutch leadership powers that be that are listening and evaluating, it's really has to become a systemic part of the culture of the cancer care center that is operating or treating you. So whether it's this type of treatment or mental health or financial health or the things that we've talked about, just focusing on, you know, the physical therapy or the movement of your body, whatever you want to call it, you know, Fred Hutch has to embrace that as equally as important as all of the research on all of these other things, the CT, DNA stuff. And, you know, so there's a systemic issue that goes along with it. And I was fortunate to work with your team 3 years ago, but the physical therapy office was as big as the bathroom, you know, so the organization has to invest in the people and the facilities and make a commitment to the practice to be able to pass it on to us effectively. So hopefully, you know, Fred Hutch, CEO, and all those people.
Yes,
you know, put that on your board meeting agenda.
Put this on blast. But yes, I completely agree.
Wonderful.
Otherwise, thank you, everyone.
Well, thank you, Dr. Hunter. And yeah, I'll just add, as a radiation oncologist, a lot of the patients that I treat do have metastatic disease, but whenever I'm giving treatment, I try to remind that we're giving this treatment so that you can live, so that you can do what you love to do the things that you like to do. So I always encourage my patients, keep doing those things that bring you joy, that bring you energy. And this is maybe a little bit of a hack, but a lot of times when we're writing our note, we have something where we say, what's the patient's performance status? And there's the ECOG performance status, it can be like scale of 0 to 5, or the Karnofsky performance status from 0 to 100. But it's something that we document. And you're only seeing that doctor for 10 minutes or 30 minutes. And in that snapshot, you have to give them a sense of how much am I out of bed? Am I someone that's walking around? Am I going outside of the house? Am I just sitting and watching TV most of the day, inactive? And sometimes insurance companies look at that performance status to see whether they will approve a certain treatment or not. So for radiation oncology, the better performance status you have, the more likely things are to be approved. That may be true in other disciplines as well. And then the second hack is that we wish we were better at predicting the future. How long am I going to live? How well am I going to do? I think one of the best predictors is, what is your performance status? And things change day to day, but if you are someone that is feeling pretty good and walking around, that's a good predictor. So use it or lose it. Keep using what you are able to do. And so I keep making myself transitions, but using what you are able to do, we're happy to move on to the next aspect of our talk, maximizing vaginal health for sexual wellness. So we have Dr. Elaine returning from last year to give us this wonderful talk. For those that may not know, Dr. Mihalov recently retired, but she gave a full career of service to medicine and so many women throughout her career. She was a clinical professor emeritus at UW School of Medicine, certified menopause practitioner in the Menopause Society, and the Department of OB-GYN at UW Medicine. So let's welcome Dr. Mihalov. Mihalov, sorry, I've been saying it wrong.
Thank you so much. It's a pleasure to be asked back today. Before I get into my talk, I have to say that I am not a natural exerciser, although I've been hearing that same lecture in the cardiac rehab I'm going to with my husband for the last 2 months. But I have a trainer because I won't do it if I don't have somebody make me exercise. And I recently was in a rural cemetery in West Virginia, out in the boonies, and had to use an old-fashioned outhouse. And I was so glad that my trainer made me do so many squats, because I could literally squat without touching the grossness around me. Okay, so now getting into our talk, I want to say that I always like to say that I recognize that not everyone with a vagina identifies as a woman, or anybody, everybody with breast cancer is not or does not identify as a woman, but this is the way most of our literature is written, and so that's what you'll hear me talk about. So our goals are to talk about vaginal and vulvar anatomy and physiology and the importance of estrogen. By the way, someone's probably going to have to tell me when I'm close to time's up. Okay. I want to review the agents that will help to enhance vaginal health when estrogen levels are very low, which they usually are for people who are either naturally or surgically postmenopausal, or who are being treated with agents that reduce their estrogen levels, and to review the benefits and risks of vaginal estrogen therapy. And if I save 2 minutes at the end, I'll tell you some good news that's unrelated. So the World Health Organization thinks that sexual health is important. So it's not just the absence of problems with it, but it's really, having a positive approach and being able to have pleasurable and safe sexual experiences free of coercion and violence. And if you are having pain when you're having sex, that feels like violence. So that makes many, many people avoid it altogether. But sexual health doesn't get old. There's no upper age limit. And so what we want to do is enhance this part of an intimate relationship for people so that they can continue to enjoy it. So if we go back to the early models of female sexual response, we see the Masters and Johnson model. If you're old enough like me to remember that, it was pretty much based on male experience of being aroused, having an increase in arousal, then having an orgasm and resolution. Kaplan came along a few years later and incorporated desire. I should have checked to see how the pointer works, but at any rate, that starts with desire rather than with arousal, and then into excitement and orgasm. And it wasn't until 2001 that Rosemary Basson from the University of British Columbia incorporated this cycle, which is much more accurate for what happens with women, which is that the spontaneous sexual desire that's in the center of that circle is really not necessarily where things start. It often starts at the top at 12 o'clock, where it's more like emotional intimacy. So being in an intimate situation can motivate a woman who is otherwise sexually neutral to actually be interested in sexual stimuli and respond, and that develops into arousal. So it's not that you have to be walking around all day thinking, "Boy, I really want to have sex." It doesn't happen that way for a lot of people who are beyond about 25 in most people's experience. So just getting into the situation, allowing yourself to have an opportunity to be intimate with a partner or with yourself, for that matter, then the desire can come, the arousal can come with everything that comes with it. So this is reassuring for a lot of people. The other main point is to talk about genitourinary syndrome of menopause, which can affect you whether you are in medically induced or surgically induced menopause or natural menopause after about age 51 or so. And this can affect not just the vagina, the inside of the vagina, but also the outside, the vulva. You see labeled here as the hymen, all this entire part that's called that we recognize as the labia. All of that is sensitive to estrogen and has different appearance when estrogen is on board and when it's not. And this condition also can affect the bladder. So people who have often postmenopausal people will have significant urinary urgency where you feel like you have to go to the bathroom all the time. It's hard to hold it. And for getting up at night more often, that can all be related to low estrogen as well. And this is kind of what it looks like. You can see the difference in the close-up photos of the histology. Let's see, do I have a mouse? Yeah. So this is normal. There's thick lining of the vaginal wall. You see those little pleats in that, the little folds in it. Oh, you're not seeing the mouse. Never mind. Anyway, on the other side, with no estrogen around, things are very smooth. The vaginal wall is very smooth and thin, and that means it's prone to get irritated and traumatized. The other thing that's important to know about the vagina on the difference between estrogen or not. See those folds on the right-hand side of the screen, those sort of sideways pleats? That's what allows the vagina to stretch. So when there's something in there, like a baby's head, or like a tampon, or like a penis, the vagina has the capacity to stretch. But when those folds are gone, as you see on the left side of the screen, where the wall is very thin and straight, it just has nowhere to go. It isn't going to stretch. So that is what the lack of estrogen does to the vagina. It's not just moisture. So if you've ever tried agents that are supposed to increase the moisture in the vagina and you found that it didn't make any difference, it's probably not just the moisture, it's probably that stretchability as well. So I was telling Dr. Lee that there's an amazing dearth of photographs, even on the internet, to illustrate this. But I'm going to show you photos that I took a long time ago, so if you don't like seeing anatomic photos, you might look away. But this is a picture of a premenopausal vagina. You can see the white secretions there. This is taken through a speculum. And you can see a little bit of those folds there. And the color is light pink. And in a different person who is postmenopausal, you can see that it looks more red, it's much smoother, and there aren't as many secretions. And if somebody wants to do a research study to take photos to better illustrate this for all of us, I would heartily support that. So, as I said, that these symptoms develop after menopause. Sometimes people who've gone through menopause without trouble with hot flashes, without other issues, feel like, oh, I sailed through it. And they don't even realize until a few years later that sex has gotten uncomfortable, that they just don't, it's painful, and they just don't want to do it anymore. And so it often happens later after the actual menopausal transition. When estrogen it declines very quickly, like it does with, for instance, going on an aromatase inhibitor or having the ovaries removed because there's a BRCA or some other mutation, that can cause more abrupt symptoms because it happens so quickly. This is a very common problem. Many people, postmenopausal people, have this, but only a few are treated. And a lot of people, like I said, don't realize that the symptoms can get worse over time or that there's treatments for this. And another interesting statistic is that when sex is good, it adds 15 to 20% value to the relationship. But when it's bad, it diminishes it by 50 to 75%. I'm not sure how they got to that data, but it makes sense. And the other part of the problem is that people don't ask about how your vagina is doing. I do. This is my area of interest, and the gynecologists at Fred Hutch do, and probably an increasing number of gynecologists elsewhere. And there are, of course, many people who are breast cancer survivors. This is a very common phenomenon. And if you add in people at high risk for breast cancer, most will suffer from GSM or genitourinary syndrome of menopause and will go untreated. These numbers are a little old, but they're probably about the same, I would say. So what we usually recommend, first of all, is lubricants and moisturizers. So a lubricant is something that you use when you're having sex or when you're having intimate contact, and it can be used with all of these other things that we're going to talk about. Lubricants come in water-based, silicone-based, and oil-based. The oil-based ones are, some people use an oil like olive oil, but that can be very messy for the sheets. Water-based might sound more natural because it's only made with water, but the silicone-based ones really are the ones that are the most slippery. They last the longest. So we find most people get best results with that. A moisturizer is something that you use on a regular basis. So just like you moisturize your skin, or you should be, or you're putting sunscreen on your face, you are putting something on your vagina and the vulva that will help to maintain its moisture. And you can use that. Some people use the same thing for both. There's products that do both things. Some people use one product as a moisturizer and another as a lubricant. And if we go back to this page, this is from the Menopause Society, which used to be called the North American Menopause Society. Their list of examples of products. These are not all the products that exist. I have a couple of samples here just to demonstrate. The Reverie, which is a few numbers down on the moisturizer list, is one that comes in a little sort of pellet, little suppository like this, and you just put it in the vagina and it kind of melts. And this is Hylogyne, which is the one on the bottom of the list. And these are over the counter, so you can buy these, anywhere you buy things that come in a brown box to your house. Or, they have them in some stores. The lubricants are items that are actually used to lubricate during sexual activity, as I said. My personal favorite, there's a couple of favorites that I have. One is called Uber Lube, which is almost to the bottom of the list there. There's another group called, let's see, are they on the list? Good Clean Love. Good Clean Love makes several different products in each one of these sort of categories. So those are good ones to look at. But whatever works for you, if you go into an adult store, there's one on Capitol Hill called Babeland. And there's one down by the airport. I notice every time I go there, just by the exit there. But usually they'll have samples, so you can try it out, test it out, and see what it feels like. Someone did a study a few years ago on hyaluronic acid moisturizer in cancer survivors and found that the 5-time-a-week schedule appeared to be more effective. And the moisturizers also come, in addition to the suppositories, they also come in a thing like this, that you squeeze the gel into this tube and then put it in the vagina and just squirt it in. That's kind of like a tampon applicator, about the same size. Although some people get good results with moisturizers and lubricants, what works the best in the studies that have been done is vaginal estrogen therapy. And even though you might be thinking, estrogen, I can't have estrogen, that's actually does not appear to be borne out by the studies. So that vaginal estrogen is considered safe for many, many people with breast cancer. I can't say all, but many. And the vaginal estrogen provides enough estrogen to work in the vagina, but it doesn't really go into the bloodstream. It doesn't increase blood levels in the body. So this is what we recommend when people only need vaginal or vulvar assistance with estrogen levels. And sometimes people who take systemic hormone therapy don't even get enough effect in the vagina, and they need extra estrogen there. There's different levels of receptors. Vaginal estrogen is available in a cream. So this product was approved by the FDA in 1946, which leads to some frustration when it comes to how reluctant some insurance companies are to cover it. It's got to be very cheap to make because it's been around that long, but they charge a lot for it. First one that came out was conjugated equine estrogen, which is the one that's made from pregnant horses' urine. But estradiol is more commonly used now, and that's based on soybeans, basically. And then in the, 1996, we got the estrogen ring. The cream is inserted into the vagina in a tube like this, which is like a, regular sized tampon, I'd say. And you can measure out the amount that you use. We usually use 1 gram or 0.5 gram a day, so it's about that much. And you can put some around the outside if you need it externally. The ring looks like this. It's a flexible solid silicone ring. You just slide it in the vagina. If you are old enough to remember diaphragms, this is smaller than a diaphragm. So this one you put in once and it works for 3 months. You take it out and throw it away and put in a new one. And then in 2009, we got the tablet. The original one that came out was called Vagifem, which, oh yeah, it's over there in the picture. And that comes in a little applicator like this with a pill on the end, which I would say is probably about the size of a baby aspirin. And you just slide this in the vagina and press the button and it pops into the vagina. And it's formulated to stick very well to the vaginal wall so it doesn't fall out. And that's different than a pill that you would swallow of estrogen. And then the more recent one was the insert called Imvexi, which I have to keep in a little case because it's so small. So this one, and I'll show you the next picture. So the estradiol tablets, Vagifem, Uvifem products in the pink there, they're all pink, go figure. The pink sticks over there, they're packaged, each individual one is in a plastic applicator, each pill, and the applicator, the whole stick and everything is packaged in foil, so there's a lot of packaging. You use this, I'll tell you that in a second. The Imvexi comes in a blister pack, so you push out the pill. So it doesn't involve as much packaging, but you use your finger to put it in. And that comes in 2 doses. The 10 microgram dose is the same as the dose of the estradiol tablet. And then the 4 microgram is a very tiny dose. So if you want to try it, but you want to minimize your dose, that would be the one for you. And then I showed you the ring. So typically we use the estradiol tablets twice a week. For most people, we start once a day for 2 weeks and then twice a week. But if you wanted to avoid the loading dose, you could. The ring you put in once and leave it for 3 months. The cream you use typically whatever amount you're measuring out, you use twice a week. And some people need a little bit of that cream on the outside because remember we started with that picture of the vulva, and those tissues on the outside are also sensitive to estrogen, so using it on the outside can be very helpful. One of the issues is the insurance coverage, and in their wisdom, a lot of the insurance companies have decided that only one of these is necessary to be covered, especially for people on Medicare. So the insurance may tell you, no, you can only have the tablets, you can't have the cream, or you can only have the cream, you can't have the ring. We do have sort of form letters that we send to them to say why you should have one or the other if you're, one of them isn't working for you. And this is, you know, sort of a crusade among those of us that care about this to try and get things changed. And there's another product that does not involve estrogen. It is basically based on an androgen. So this is DHEA. And this is a daily vaginal insert that comes like this. You load that little pellet, which looks sort of like these, into the end of the applicator and put that in the vagina. And this one is not estrogen, it's more like a version of, it's not testosterone, but it's an androgen, a male type hormone that's converted into estrogen. And that does not have a warning against use in people with breast cancer. All of these approved the products that are approved by the FDA, these are all prescriptions, and they all have about the same efficacy. So you use whichever one works best for you, and whichever one, of course, that your oncologist is comfortable with. Are most of you from not getting your care here at Fred Hutch? Are people getting their care elsewhere, in other places other than Fred Hutch? Okay, I can tell you that with minimal exceptions, all of the breast oncologists and oncology providers here at Fred Hutch are comfortable with their breast cancer patients using vaginal estrogen. Would you agree, Dr. Lee? That's what you understand?
Yeah.
Okay, so if your provider is reluctant, you can tell them that. The providers at Fred Hutch are comfortable with this. So we talked about that. What are the risks? The FDA requires any product containing estrogen to have a black box warning that says it can cause breast cancer, even though there's no scientific data that indicates that these products cause or exacerbate or increase the risk of recurrence of breast cancer. And the studies that have been done on these vaginal products have not shown any increase in any of these serious complications. And they don't cause uterine cancer like systemic estrogen can if it's taken by itself. And this is just more information about the safety. I'm sorry, we've sort of gotten ahead of ourselves there. So the Women's Health Initiative, which was a big study that came out in 2002, which was very influential in terms of the benefits and risks of hormone therapy, did look at breast cancer and other side effects in people who took vaginal estrogen only in that study, and they found that users and non-users had similar risks of breast cancer, stroke, colorectal cancer, endometrial cancer. So there was no increase in risk in those people who were not taking the systemic hormones that the study was based on, but who were using vaginal estrogen. And hot off the press, in March of this year, a study in the American Journal of OBGYN did a systematic review looking at multiple different studies that had evaluated vaginal estrogen use in breast cancer survivors. And they found that the use of vaginal estrogen did not appear to be associated with a risk of breast cancer recurrence, breast cancer-specific mortality, or overall mortality. These studies did not differentiate, to the extent that I could tell, whether they were breast cancer survivors or people currently dealing with breast cancer. So that's why you would want to check with your oncologist about the safety. And like I said, they're required to put this class labeling, and the Menopause Society has approached the FDA on several occasions to try to get them to change this labeling, because everything from birth control pills to postmenopausal hormones that you swallow to vaginal estrogen has the same warning, and it really is not scientifically based. So we could provide these slides for you if you're interested in the details here. What?
Dr. We may need to move to the next speaker.
Okay.
Maybe 1 minute.
Great. I can right now, or can I have 1 more minute to wrap up? 1 minute. Okay. So other options for what can be done are you can use vaginal dilators. And sometimes people who have not had any sort of insertional sex for a long time need to use dilators to help the vagina open up. Pelvic floor physical therapy can be helpful, not to tighten, but to learn how to relax. Because if you've had pain for a long time, that can cause you to have a reflex reaction to tighten up. There are studies underway on multiple different forms. There's no scientific evidence for the use it or lose it, so it's not irretrievable. Even if you haven't had sex in 20 years, 30 years, you can. And there's no good use for vaginal estrogen for this, and there's no evidence for any botanical therapies being useful, except coconut oil we recommend a lot because it's safe and effective. And these are my references, and that's the end of my talk. Thank you for letting me know when it was done.
Wonderful. We will group the questions at the end. I'd like to thank Dr. Mihalov once more. And next we have a new speaker with us. Really pleased to welcome Dr. Matthew Gibbons from our palliative care team. So he's assistant professor in our clinical research division at Fred Hutch and assistant professor at University of Washington School of Medicine. His talk is titled Palliative Care, Helping You Live Well with Metastatic Breast Cancer. So Dr. Gibbons, thank you so much for coming today.
I just want to start by saying thank you for having us. It's really a great privilege to be here with you to tell you a little bit about our work, about a little bit more about our team and how we might be able to integrate into your cancer care. I have no disclosures to share for this talk. Just to give you a little bit of an outline, we'd like to spend a little bit of time highlighting the complexity of metastatic breast cancer. And then from there, talking about what is palliative care. Hopefully, we can springboard into how can palliative care help me? And then I'd like to finish this talk with just a few patient stories, leaving a bit of room for questions at the end. We know that skeletal events, visceral complications, and hematologic and hormone complications are inherent in disease progression with breast cancer. We also know that treatment related to breast cancer causes its own host of complications. That is only remarking about the physical impacts this disease has to a person, not speaking about the emotional, spiritual, and social complications. So knowing all of that, we think, what is palliative care? And I'm looking in the room, I'm just curious, if you have heard of palliative care before, could you raise your hand? Wow, I have never seen this many hands raised in the room. I hope that mirrors our participants online, but if you'll indulge me, I'm gonna talk to you a little bit more about what palliative care is. So when living with serious illness, our team, we like to say that we are an extra layer of support. I want to highlight that we work collaboratively and closely with your healthcare teams. That involves your primary oncologists. Maybe if you're involved with radiation oncology, I will tell you Dr. Hanna Hunter, who just talked about exercise, we work routinely together. We hope to address concerns that impact quality of life during treatment. As I mentioned in my introductory slide, we recognize that is not always just limited to the physical. We as doctors are really good at working with the physical. And we in palliative care recognize there are multiple domains that your cancer care impacts, including, as mentioned, emotional, your spiritual, and your social intrapersonal connections. All of this is with the ultimate goal of how do we help you feel as well as possible for as long as possible. If you'll indulge me one more second, I would like to talk about the elephant in the room. Everybody says the word palliative, and immediately we jump to hospice care. Or how many times have I heard, I don't need palliative, I'm not dying. I would like to dispel that myth and that rumor today. And let's look directly at what is palliative care and what is not palliative care. And so I want to highlight that palliative care is available at any age or stage of illness. When we think about hospice care, this is specialty end-of-life care that a patient is only eligible for the last 6 months of their life. With palliative care, we support patients getting any form of treatment, which might include chemotherapy, radiation, or surgical intervention. Whereas our hospice colleagues approach with a comfort-focused primary goal, and they minimize life-prolonging treatments. In palliative care, as I've mentioned before, we work collaboratively with our specialty providers to assess, prevent, and relieve suffering. Whereas patients enrolled with hospice, the hospice agency becomes the patient's primary medical team, and all care is assumed under the hospice agency. I will tell you, for some patients, hospice plays a very profound role. Palliative care is different than hospice care. So now that we've maybe spoken about what we're not, what are we? So I wanted to talk a little bit about who our team is and how do we provide care. Our team prides itself on being an interdisciplinary team composed of nursing, physicians, advanced care practice providers, clinical social worker, a pharmacist, and a spiritual care chaplain. We all work together and collaboratively within our team to deliver specialized holistic medical care. And we recognize that there are patients that are being supported by friends and family members. That is just as important to recognize and support. As mentioned before, we focus on preventing and relieving suffering, with the goal of supporting the best possible quality of life alongside your primary oncology efforts to treat the underlying illness. And remember that this is all available from the time of diagnosis throughout the life of the individual at all stages of the disease. One of the biggest elements that I work with my patients is alleviation of physical symptoms. And I would like to say today, you can live well while living with metastatic breast cancer. I know that to be true. We always try to give you the best care for your symptoms. And we understand that each individual is different. So we work with you to tailor your medication regimen to find the right combination that works for you. While medications are one of the tools that I work for, we recognize that there are non-pharmaceutical interventions that can be just as effective. And we utilize that in our approach to optimize your symptom management. All with the goal of identifying what's most important to you and how do we use the tools at our disposal to make that happen. I would be remiss if I didn't mention the social, emotional, and spiritual aspects of symptom management. It is not uncommon for people with serious illness to experience psychological and existential distress, not only for themselves, but in their family and support systems. We recognize that quality of life can be significantly impacted, that anxiety also affects patients living with serious illness more than the general population. It's often coupled with fear and worry and apprehension about what lies ahead. And living with uncertainty can be very distressing. We recognize that existential distress and demoralization can also be present. And the palliative care team works to address these concerns and discuss different ways that we can help you cope through this element of the illness. We in palliative care are housed under the supportive care services here at Fred Hutch. We work alongside many of our colleagues listed here, that if we identify a need that you have, let's get you connected with the specialty experts that can support you in addition to the work that we are doing as your palliative care team. Communication is so important in cancer care, and we recognize that from the palliative care team. We also recognize, as you saw on the slide before us, a lot of our patients have many different teams that they're working with. I would encourage you that if you work with the palliative care team, you can always call us to figure out who is the right person that we should be speaking to. And if we don't have that answer for you, we will get you connected with the right service. We also offer support for the family system in navigating changes in the illness course and transitions in treatment. And I think lastly, I would highlight that we also assist with completing advanced care planning documentation, which I encourage my patients as a way to think about how can my wishes be honored even in the event I can't speak for myself. We strongly encourage, for example, that all of our patients, regardless of what stage of disease, complete a durable power of attorney for healthcare, which is just simply who is that person my doctors talk to, even if I can't speak for myself. If it hasn't become apparent yet at this talk, I want to drive home, we really do believe in supporting patient autonomy and advocating for your choices, because we recognize that treatments only work if they work for you. Palliative care approaches treatment planning in a way that supports patient autonomy in the context of systems of care and close family members and caregivers. We encourage you to talk to the people who matter most to you. It's not uncommon for our team to facilitate a family meeting if that's what is in the best interest to support you, or to work with a collaborative meeting with all of the teams that are overseeing your cancer care. We encourage you and hope to empower you to speak up, because we recognize you can get the care that's right for you. I'd love to take a moment and just talk about a patient story. One of my patients who had metastatic breast cancer. She came to me. At that time, her disease had spread to her bones, and her most troubling symptom was pain. As the cancer pain specialist, we worked on a regimen that supported her goals because she was working a full-time job and had a passion to support coaching, volleyball, and basketball. Some of my medicines caused sleepiness. That was not acceptable to her. So we had to optimize what are the medicines we can use during the daytime, coupled with the medicines that we might try at nighttime, to ensure that her pain was controlled and she was able to pursue the passions that brought her joy. As I mentioned, palliative care is open at any stage of the disease. I worked with her over the course of several years. As we had disease progression, our goals shifted. And we began focusing on how do we make sure what is most important to her is being honored and heard. And ultimately, when we ran out of disease-directed therapies, she realized what was most important to her was to be at home with her family. And we talked about how can we make that best happen with the decision to enroll in hospice care. I will tell you, it was a great privilege. I always try not to say this patient's name. It was a great privilege to work with her. And I hope that we bring that energy to every patient that we get the chance to work with. A few of my colleagues wanted to share a few of the quotes that they've heard from their patients, including, "People often tell me that they've had a hard time believing that I am as ill as I am. I tell them that the care I am receiving makes the difference. After almost 2 years with palliative care, I feel like they know what is important to me, and they do a great job helping me achieve my goals. Another patient remarked, "For me, a lot of it is pain management, but that is far from all they do for me. They address my psychological as well as physical needs in a variety of ways. I could not be more grateful for this outstanding group of people." I've gotten my life back now that my pain is well controlled. Thank you for the compassionate and pragmatic support. And this one breaks my heart, but I hear it with decent regularity. I wish I had seen you earlier. So I hope that this has given you a better understanding of how palliative care can partner with you and your healthcare team to help you live well. I would encourage you that you can ask for palliative care at any stage of disease. And we welcome and hope to see you in the future. And with that, I'll pause for any questions.
Dr. Gibbons, thank you so much. That was very moving, and as a fellow physician, I want to echo what you say, that I feel like as a patient, if there was something there that resonated with you and you don't currently have a palliative care provider, that is something that you can bring up at your next appointment. And I think we've seen in this conference so far, there are a lot of complex dimensions to navigating and dealing with the cancer diagnosis and the hurdles that come. And your oncologist, your radiation oncologist, your surgeon, they may not be able to address all of the things that they want to with the time that they have in that visit. By having an additional layer of support, an additional member of your team, it creates a new space. You reset and you enter with kind of a different intentionality for that visit, and you can cover other things. So kind of without belaboring the point, I think early integration of palliative care is amazing. Hopefully we don't make Dr. Gibbons' team too busy, but that shouldn't be your problem to think about.
We welcome that challenge. Thank you again.
Yeah, but a huge desire, thank you to Dr. Gibbons. And next to complete our trifecta about taking care of yourself, not just for the patient, but also just as a family, as a couple, as a household. So I want to welcome Ray Wiseman, who's here to speak. And their talk is titled Meaning Making and Spiritual Well-Being.
Hi everyone. Thanks so much for being here. My name is Ray Wiseman. I've been here at the Fred Hutch for 8 years now, and in this field for going on 20 years. And I'm happy to get to share with you a little bit of what I've picked up along the way. And here we go. So what I like to say when I call and reach out to somebody is that spirituality means something different to everybody. We all have our own backgrounds and belief systems and experiences that shape our unique worldview, and I am here for all of it. I love to hear every all kinds of belief systems, all kinds of experiences. It's really joy to get to walk with folks on this journey and just get to know a little bit about what makes you all smile and cry and love and feel. Really, what we are here to do is just set up a safe space to listen. My job's mostly a lot of active listening and reflection and helping folks to get connected to whatever their own sources of peace and meaning and joy, hope, strength, faith, if that's your thing. I'll say a little bit more about that soon. We do in-person if you're at the clinic during treatment. We do telehealth a lot, and even phone visits if you ever just want to pick up the phone and call somebody and have somebody listen. That's really what we're here for. So, but I do want to just say one of the major things that I'm here for is just to hold space for grief, because it's real and it's hard to go through this journey or life in general without a little grief. So the last thing that me and my team will want to do is rush you through that grief, right? Because we all just go through it in our own time, in our own process. And I really like this poem. I'm going to read you a little bit of it. Let us agree for now that we will not say the breaking makes us stronger. Let us promise we will not tell ourselves that time will heal the wound when every day our waking opens it anew. Perhaps for now it can be enough to simply marvel at the mystery of how a heart so broken can go on beating. It's really nice when people want to encourage us and say, oh, everything's going to be okay. Look on the bright side, silver lining. It can be helpful sometimes, but oftentimes that just shuts down the conversation. So just want to let you know that, we're here for it in spiritual health. We all want grief to be linear. We want to get through it as soon as possible. I don't think anybody really enjoys it, but it's not like that, we get better, we go back and forward, like this graph, how grief actually works. So, one thing also that, we found is that connecting to a source of faith or trust is another word for faith, I like to say, can help us to get through some of the heaviness, the fear and the grief and the anger that inevitably accompanies having to be a patient with us. So I like to talk about these three realms of faith. Faith in ourselves to begin with, faith that we can get through whatever hardship that we're being confronted with, faith that we can connect with joy and meaning and dignity along the way. Faith in others, be that our friends and our family, our medical team, humanity. And then sometimes people get to connect with faith in something bigger, be that a higher power, a God, an order to the universe, nature, the cycles. And so all of those ways of tapping into trust or faith can help to bring us a sense of peace and sort of lower our nervous system and relax and let go and see what happens and be open to the mystery. So when I say faith, sometimes it just means those kinds of faith. It doesn't have to be anything religious. Of course, we are here and we love religious expression as well. So just to let you know that faith doesn't always have to be what you might think of when you find in church. It can be found in the woods or in a book or certainly in the smile of your loved ones. And this is another thing that I like to touch on. This picture is out of from a movie called Inside Out. It's a Disney Pixar movie. If you haven't seen it, I really recommend it. It's all about feelings and it's just fabulous. I actually watched it in my residency training, and really kind of the whole moral of the story is that, our tears are kind of to signal to each other that we might need some support, and grief can bring us together. So it's one of the ways that we find meaning in the hardships of our life is to be able to learn something from our hardships and then share it with others and help them and support them on their journey. So I'm going to do I know we're running behind time, but I'm going to do like a really quick check-in for everybody. I'd just love you to just think of something you love, something, it might be a person, a pet, a place, a thing, and just share it really quickly with your neighbor. And it's just kind of one of the ways that we can connect with each other. I don't know if you guys have all gotten a chance to say hi to anybody, but if you see somebody near you that you can just share with, just take like 1 minute to do that. That would be great. Okay, I'm gonna wrap us up in the interest of time and move on and tell you a little bit more about why I wanted us to just tap into that. So, sometimes I get to talk to people who don't really know what their spiritual expression is, and so sometimes I start with that. Well, what do you love? What makes your life meaningful? What brings you joy? So those kind of lead me to kind of understand what spirituality or spiritual health is to people that I speak with. So what you shared with your neighbor might be a clue to, if you want to start to develop even more your spiritual journey, start there. See what's sacred about that. Another way is what brings you awe, a sense of awe and wonder in the universe. There's a lot of mysteries of the universe, and that brings me a sense of awe and wonder. Looking up at the night sky and, wondering what it's all about and where it all started. And yeah, just being able to engage in these kinds of spiritual experiences, practices, conversations can really open us up to having those connections that we might not have been able to nurture before. So I always like to suggest setting up like a place in your house. Sometimes you call it an altar, maybe on the mantelpiece. You have pictures or little trinkets or something you love. And that can just be a safe, sacred place where we just check in with ourselves and connect with, something greater. Maybe it's your loved ones, your ancestors, or whatever fills you with a sense of awe and wonder. Meaning making, of course. I really like this comic, even though it's got a grammatical error. And it's, we are going through this process of change. The only constant in the universe is change. And so some of the things that spiritual health clinicians do with folks is make a space for trying to find a sense of meaning from what we all are going through. I won't belabor the point. I'm sure you guys all know what I'm talking about. But it can be helpful to even just remember that we're all in this together. Even if you're, even if all you ever do is tune into this this conference from your home, you make a difference. You matter, and so we're all part now of the Fred Hutch of the large organization. And whether you participate in a clinical trial or not, you're helping us learn how to beat cancer and how to live well. So that's a really solid way that I can tap into a sense of meaning and but even learning different roles in life, right? If you've always been the caretaker, then learning how to be the care receiver can be a meaningful experience, even though it's really hard. And I just want to acknowledge that. Self-care is also a spiritual practice. So these bodies, they're incredible, amazing things. And sometimes it can be boring to take care of them, to be honest, brushing your teeth, things like that. But it's just, it's a wonderful experience to be able to recognize our own inherent self-worth and be able to take care of ourselves. And one of the analogies that I like to talk about when talking about self-care is, you've probably all heard the oxygen mask, put on your own oxygen mask first. So my favorite analogy is comes from, you can't pour from an empty cup. So the idea of this analogy is your self-care practice, whether that's your spiritual practice, walking in the woods, or taking baths, or getting massages, or whatever, is the font of your spiritual well-being. And so I would invite you to imagine taking your cup and finding your font and filling up your cup. And then that overflow, when it starts to overflow, because you're so well taken care of, then everybody else can come and they can fill their cup on the overflow of yours, rather than pouring from your cup to everybody else and then you have an empty cup, right? And so when we take care of ourselves, we are able to exude that sense of peace and care and compassion for others, right? And so just a kind of a nice way I like to think about self-care, that it's, it's not selfish to not pour out all your energy for other people. It's just a wonderful practice. Just find what lifts you up, and I hope that we can all access that without feeling guilty. So some of the one of the things that fills my cup is cute animal videos and pictures. So I put on a couple of ideas. Obviously, you guys everybody has their own spiritual practices, but I listed a few here: yoga, stretching. But I want to share this one, self-havening, that I really like. I'm gonna ask you all to join me in this. It's a very easy exercise. I'm gonna put the microphone down while I give you a demonstration, but it's called self-havening. And what it does is it actually triggers a release of oxytocin, and it works within seconds. So, 1 second. Please join me. And you can do it anytime. Anytime, just give yourself that love, give yourself that hug. Do you feel it? Yeah. I also want to just one little throw it out there. Rest and relaxation are so important. A lot of people, when they are patients with us, they're going through some kind of treatment, and their bodies are working really hard on overtime on a cellular level. And we don't actually kind of take that into account when we think of like, oh, I don't want to sleep. I'm sleeping more. I don't want to rest. But you're working so hard. Not even if you're in active treatment, but just to process everything that's going on, right? So just really want to emphasize that the importance of that rest and relaxation and self-care in that way. And to kind of close it all up, I really love this analogy also, that we're all puzzle pieces in this complex universe, and we all have a really important part to play. And even if we're not, doing anything and we're just being, that still matters. You still matter. There's this saying, you're a human being, not a human doing. And so I just really want to thank you for being you, and I hope you keep it up, and hope that you make a call, and you can call that number right there and get an appointment with me, and I'll give you a call, and we just have a chat if it all feels like that would be helpful for you. I'd love to speak to each and every one of you. And thanks so much for being here and listening to my presentation.
Wonderful. We have opportunity for maybe 3 questions in the audience.
I have a comment and a question, and it's about the sexual health. My comment is that 2 years ago, I was diagnosed with metastatic breast cancer, and I had an S ring, and my oncologist thought that was part of the reason I got cancer. So just letting you know, he was from Swedish. I think he was a bit of a quack, but okay, I'm just telling you. So you know. The other thing is about vaginal health. If you're not sexually active, I'm not ruling that out, but if you're not, is it important still to have, not an atrophied vagina, to do something for your vagina?
So the question is about, do you need to maintain your vaginal health if you're not using your vagina for insertional sex? And the answer is that's up to you. And it depends on whether you're having any symptoms. So some people with vaginal or vulvar dryness, external dryness, are really bothered by it. Their labia sort of get stuck together, or they just have, sometimes people can have sort of a yellowish vaginal discharge. And those are things that can be treated usually without even estrogen, just with the moisturizers. And the other thing is that there is an association between atrophic changes in this area and increased bladder infections in older people. So vaginal estrogen use has been shown to reduce the incidence of recurrent bladder infections in older people, which sometimes, in quite older people can present as kidney infections or sepsis. So that can be valuable as well. But it's really up to you.
Hi, I just have a quick question. Dr. Givens, I think if I heard you right, you said palliative care is housed under supportive care. Is supportive care, is that housing palliative care and anything else? Or what does supportive care at Fred Hutch have that you don't have?
Yeah, supportive care is just the larger umbrella of where our group sits. So things like integrative medicine, psychiatry, psychology, we're all housed under supportive care, which is designed to support the medical oncology treatment that you're receiving. So I apologize, it's just institutionally, that's where we sit.
And I might add that some of you may have experienced a hospitalization, and oftentimes that's a patient's first encounter with palliative care. Palliative care does have an inpatient presence, but it doesn't mean that's the only way that you can get it. And so there is outpatient palliative care. Similar to radiation oncology, we're a little bit at the end of the line. You won't get to us unless someone refers you to us.
And I might just add to that I am on the inpatient team as well as the outpatient team. So I might see you inside the hospital as well as outside the hospital, recognizing that we realize your problems don't stop when you leave the hospital. And we do believe that continuity is important.
May I have 1 minute for breaking news?
Yes.
You may have seen advertisements for a product called Mendoza, which is called fezolinetan, and that is a drug that treats hot flashes. It does not treat the vagina. It does not treat and is not associated with any other benefits to the body, but it helps to reduce hot flashes, especially in people who are unable to take estrogen for one reason or another. That product was FDA approved maybe 1.5 years ago, and the second one in that same class, elinzanetant, was just approved last week. And that these are both products that work on the brain in the thermoregulatory center of the brain. They reduce the products that cause hot flashes. They're not hormones. There's no reason to think that they would be associated with estrogen or breast cancer in any way. And the elinzanetant, which was just approved, has been studied even before it was approved. It was studied in people who were taking breast cancer treatment like tamoxifen or other products. So these are valuable products that probably are not covered very well by insurance yet. But it's a new class of drugs that can be helpful for symptom relief in situations where we're avoiding estrogen. Thank you.
So question. I have a question for palliative care doctor and a comment for you. Last year you were here and you made a comment that, well, I guess I could say was kind of life-changing for me. It was a similar presentation. You said, the vagina is the one area, or you might have used the word organ, I can't remember, in your body that can age backwards. And I was like, oh my God, there's hope. So thank you for that, because I've shared that many times with many people. So my palliative care question, we deal with a lot of this, doctor says this, and now I'm going to this one, and now I'm going to this one, and now I'm here at this one, and, now here's another one, and, you're making, we're recommending these medications or this, that, or the other. From the patient side, sometimes it's like, who do I listen to? Versus like a single point of contact kind of thing. I go just back to my oncologist for a baseline. But I guess the question would be, what's going to be the difference, if you will, between how your team would guide me versus my regular oncologist?
It's a great question. I would like to emphasize that we work collaboratively with the oncologist. Oftentimes, patients are referred to me because there's a symptom that the oncology team is struggling to control. And so they will send a patient to me to say, I need help with this. Or we might have different medical treatments that we could pursue that both have risks and benefits. And a patient is really struggling to say, how do I navigate through this choice? So let's develop a framework to work together. I will say sometimes you highlighted a point that doctors might see things differently. I would argue what we do in palliative care is really centered in understanding what is the question and how do things work. So if there's ever disagreement between my colleagues and myself, we always go back to say, how does this medicine work? What is the symptom we're trying to address? And oftentimes, in so doing, that tension or discrepancy goes away.
Wonderful. And one comment on Ray's presentation, the emphasis in being intentional about your rest time and your relaxation. I know we talked about exercise, and just in the same way, you see the exercise scale, are you doing a 1 to 3, a 3 to 4, 4 to 6? There's moderate exercise. You can push yourself a little bit. When you're resting, think of a reverse scale. You don't want to be resting and being bothered and poked all the time to do all these little things. You want to try to find some nice rest where you're in pure rest. So you guys deserve that. That's something you can make aware to friends and family, caregivers. But I thought was a really great point, Ray. You can say thank you.
Thank you. Yes. You're doing great. Okay. I just want to say you're all doing great.
Okay. And with that, you guys are doing amazing. We have more speakers we want to get through and give enough time. So thank you once again to our wonderful panel. Okay, next up we have a very special talk. This is about advocating for yourself during visits. So advice from someone who has been in the same shoes as a patient, who's also had the reverse role of also being a doctor and is familiar with both sides of that interaction. So I'd like to welcome Dr. Silvia Corral up to the stage. Again, visiting from Santa Barbara, California. Thank you so much, Mom.
So is this how I do it? Okay. This is Finding Your Voice, perspective from a doctor who ended up having to walk as a patient. And now, because of finding my voice and knowing how important it was, I work as a medical advisor and a medical advocate. Let's see. I always like to acknowledge this beautiful land. I had a chance to work here in Mount Vernon, and it's just a land full of a lot of spiritual history. And so I just want to thank all the different tribes that provided and kept this land sacred for us. So we women, and some men, are amazing advocates for others. But the irony is that we excel at advocating on behalf of everyone else. We look after children, we direct reports, we help our colleagues. We will go to bat and defend the value and contribution of others who are in their sphere. We excel at making a difference in the lives of others. But ultimately, women, we've had to get noisier on behalf of ourselves. Every woman needs to begin with the premise that we deserve. In other words, becoming a self-advocate is recognizing your self-worth, like Ray said. This is about recognizing how much we are just because we need to be here. Let's see. So here's my story. I was a physician with over 35 years of practice. You can see there, I look very professional. And in August of 2012, I was a few months late for my mammogram and came, and then I saw this look on the face of the radiation technologist, like, and I said, oh, this is bad. I walked with her over to the radiologist, who was a colleague of mine, and she said, this is really, really bad. We called, and that afternoon I had a biopsy from another medical colleague, and it turned out to be triple-negative breast cancer, invasive lobular, and a pleomorphic cell type. So because I had colleagues, I got very VIP care. I ended up getting a bilateral mammogram, MRI. I got to see an oncologist before surgery. This was before they had started neoadjuvant therapy as the standard. And I thought I had everything covered. The oncologist said to me, don't worry. That core biopsy is wrong. Invasive lobular is always estrogen positive. I said, okay. So I went, had an outpatient surgery mastectomy, and believe me, this was August 8th was my diagnosis. My mastectomy was August 20th. That's VIP care. And what happened next was kind of just shocking. No one called. I called. I said, look, what's my biopsy? It's bad, isn't it? And I got a call back from the nurse, and she said, yes, it's triple negative, invasive lobular, pleomorphic cell type, and you're scheduled for this appointment and this appointment and this appointment. And I said, what? Because guess what had happened? I was in a box. I had entered the unknown reality of becoming a cancer patient. A nurse calling you instead of my medical colleague. A list of appointments with being told what to do. And me, I was on this lifeboat called panic, fear, anxiety. I knew what my diagnosis meant. And suddenly I wasn't the expert. I wasn't in control. I was on a roller coaster. And deep inside of me, I heard this little voice. And it said, something is wrong. This isn't going the way you want it to be. And if you don't change the course, you are going to die. So I fired my oncologist. I said, you can't afford to call me. I can't afford to be your patient. And I found an oncologist who would fight for me, just like I fought for my patients. She took my pathology results to a breast conference, talked with 3 or 4 different people that were divas. They knew that this was a very atypical breast cancer. She talked with a second opinion over the phone at Cedars-Sinai. And I got put on a treatment that at that time wasn't standard of care. Now it is, but at that time it was just at the beginning. And it was because of that decision, listening to that little voice inside of me that said something's wrong, and finding my own voice to fire a doctor, it saved my life. And I believe that that's the reason I'm here. You know, Ray talked about meaning. So talking to you about becoming a medical advocate has become part of my meaning, my reason, my purpose for being here. I want to tell you what is and is not advocacy. the why do you need to become an advocate? The how, it's a behavioral skill set, and a little bit about navigating your doctor visit. I call it becoming your CEO, and then a summary. Medical advocacy is, or becoming your own self-advocate, is the ability of an individual with cancer to overcome the challenges in getting your preferences, needs, and values met. Now, these doctors have told you that it's sort of very easy to do, you know, the speakers here, but these are very uncommon, very unique speakers. For the most part, I think you do need to have a strong voice in order to get your preferences, needs, and values met. It's a method of addressing the power and the information disparities between patients, providers, and the larger medical system. The medical system has a different language. Nothing can be done without a doctor's order. Even getting to palliative care means that you have to get the referral from your oncologist to get there. So it is not a system in which we are in any kind of control. So we have to become an advocate in order to become a partner. This is what it's not. It is not becoming a squeaky wheel, you know, the person that's complaining all the time. None of us want to become squeaky wheels. It's not becoming an adversary, which means it's you and against me. You know, this isn't a fight. And it's not about worrying whether we're going to hurt someone's feelings, be rude, you know, and make them not like us. And because then if they don't like us, they're going to give us worse care. Self-advocacy doesn't mean you have to wave a banner, fight, give speeches, climb walls. It means that you arm yourself with a set of tools and skills to feel comfortable asserting your needs, communicating clearly, and ultimately it means that you take responsibility and control of some of the circumstances in your life with cancer. So why? Because everything that I've read, all the research papers, in support groups, I can tell you that I have taken care of people with metastatic breast cancer for 13 years now. And the women that join support groups, they live longer. Women that learn to advocate live better. It impacts our quality of life. We may not have a long life, but we can have a life of excellent care. We deserve to be heard. It lets us continue being positive. It promotes our internal strength and allows us to be partners with our healthcare team. It builds confidence in the way that you can face all the different challenges, because all of you know there may be a decision to face at your next visit. And you need to be able to say, I have the tools, the skills. How am I going to deal with that decision? It improves our quality of life. And this is the last. It made me go from feeling helpless, hopeless, full of fear, into feeling hopeful and a way to address my fear. So it's a behavioral skill set. I thought I had it because I'm a doctor, but I really didn't. Not for myself, anyway. The first step is you have to clarify what it is that you want, what it is that you deserve, what is it that you need. And it can change as you go through the process. Today, at the beginning, it's this. In 2 years from now, it may be this. And at another time, it may be this. But that value clarification is so important in order to be able to advocate. You need to have information. How do you seek it? getting online help. I mean, these resources today have been great. All of them have given you different ways and places to go find information. We need to learn how to communicate, how to ask questions, how to make lists. How many of you make lists? Great. How many of you make more than one list? Me too, right? And then we need to know how to communicate that. Sometimes I just hand it, other times I read it, other times I write it ahead of time and hand it. Problem solving. How do you make a decision? And you need to figure out how to make that decision with a team, whether it's your husband, your family, your doctor. Negotiation. Every decision is not a black and white decision. So I have had people that say, I need a break. I want to take a vacation. And they're right in the middle of treatment. Okay? But something inside them says, I want this vacation, right? That little voice. So how do you negotiate that? There is a way. So you need to have information, you need to have communication, and then have the team be willing to problem solve with you. Because our journey is a roller coaster. And when I called about building your team, your family, your friends, your support groups, think about it. I made a list of what I called my Sherpas. These were the people that I was going to count on to help me through this journey. Dr. Patricia Gantz, who's a founding member of the National Cancer Coalition of Survivors, wrote, healthcare professionals also face ongoing pressures, such as shortage of nurses, restrictive reimbursement policies for healthcare services, and all of these have an adverse impact on the care you receive and the system in which it is provided. So our mutual interdependence, she's talking to patients, for responsible advocacy can strengthen the steps of care in which cancer treatment is received. This is an oncologist basically saying, we need to partner with them because then they can become better advocates for us. And I think that's also what Dr. Givens was saying in his palliative care. You need to tell us what you need, what you want, what you deserve, and then we can, as a member of your team, advocate for you to get that. So, at the visit, you are the CEO. You have to remember that that doctor, that provider, sees many patients in a day. But we, as patients, we only see that one doctor. And there are challenges, like systems communicating, reports getting in there, labs that are supposed to be there and they're missing, right? Time, 10 minutes, 15 minutes. And then interpersonal issues on both sides. I have known of doctors that have had the call saying that their patient just died and having to walk in to that next doctor visit. And then the patient on the other side having all of these huge expectations from a doctor who's probably trying to keep grief away. Those interpersonal issues are there at the doctor visit. So how can we manage that? Again, the list. It's hard to remember every little detail, all the questions you might have, what your symptoms are, and having it handwritten for me was always very important because it's so much easier to read something and understand it and ask questions about the list than it is actually to absorb information that is given to you audibly. Bring someone with you, a witness, your personal advocate, someone to stand up for you if the doctor says something and she knows and feels it in your body that that's not something you want, or someone that can listen for you, that can write things down. Identify your goal. I tell people, before you go into the doctor's visit, repeat, by the end of this visit, I want blank. I want a referral. I want to know the next visit. I want to know plan B. I want to know whatever it is. If you have that sentence, then you will not leave the visit without getting what you need. Bring copies of reports, especially if they've been done other places, and ask for copies of your report. Everybody needs to keep their own folder. Bring your medications and supplements. I can't tell you how often the medical record is wrong in terms of what it is it says you're taking. And then the last thing I want to put out there is, at the end of the visit, say, how can I keep in touch with you before our next visit? Especially if it's been a change of care or a new medication that's being given. You know, what is it? I have had doctors give people their cell phone because they ask, how is it that if I need to reach you, how do I reach you? If you don't ask, you don't know, and then find out that they've left on vacation. I was so frightened when I was first diagnosed, but I couldn't stand feeling helpless. So I decided I had to actively participate in the treatment received. Doctors tend to treat symptoms. I insisted that my doctor treat me, the patient, the person. I insisted on a dialogue. And when the treatment was determined, I wanted to know the purpose, the side effects, and the alternatives. Then I researched everything. I don't know if it can be measured, but I know that it helped my recovery. I have heard this so often. I have seen this often. 13 years of dealing with women in metastatic breast cancer. A quick story. I had a patient named Eva. I'll call her Eva, it's not her name. She was an engineer, metastatic breast cancer. Wanted to continue working full-time. Okay? Why? It was her job. She was good at it. Her husband thought she was good. Plus, she was tolerating the medications without any side effects. And the doctors kept saying, oh, you're doing so good. You're doing so good. You're doing so good. And in the support group, she'd come in and say, oh, I'm not sleeping. I am so tired. I don't know if I can keep up with that. And if I leave and if I, after I come back from my visit, they don't do the work for me. Don't they know I have cancer? They pile it up. They were treating her like she was normal because she was there full time. They didn't adjust the job. Guess what? Cancer markers went up. And in the support group, we're like, well, what do you want? What do you need? And with value clarification, even informing her that just having the diagnosis of metastatic breast cancer makes you eligible for disability. No questions asked. It's an automatic disability. Okay. No one had told her that. So guess what? She filed for disability, quit her job. You know what happened to her cancer markers? They went down. You know what she did? She got Reiki, she got yoga, she became a Reiki master, and she's a happy grandmother still alive with stage 4 metastatic breast cancer. So becoming your own advocate is very real. It's therapeutic. There's a handbook, but this is what I like. We're climbing mountains, and it's not a journey that we do alone. We need our Sherpas. In 2012, when I was diagnosed, my son was going to medical school, and he wanted to stay home and take care of me. And I said, nope. You become a doctor. My job is to stay alive so to see you graduate. So thank you for your journey.
Okay, thank you. That was a really nice talk. Yeah, so I know that we have a group online who they're ready? Okay, so we will welcome them next, and then maybe we'll have a moment for a brief pause, intermission before we begin our last section on clinical trials. But we're very happy to have Share Cancer Support here. Yeah, I hear some woohoos in the audience in case you can't hear that. But thank you so much for joining us. You have our undivided attention, and thank you again. Kathleen, when you're ready, maybe unmute your microphone and try talking.
You hear me?
Yes.
You can hear me? Okay. And can you see my screen? Yes. Okay. Thank you so much. Sorry about the technological issues. Hi, everyone. Thanks again for inviting me here today. I'm Kathleen Vieira Pfitzer. I'm the Metastatic Breast Cancer Program Director at Share Cancer Support, and we're a national nonprofit organization based in New York City. And I'm really excited to be here to share all of the programs and resources that Share offers for people living with metastatic breast cancer. As someone living with metastatic breast cancer, I know how hard it can be to find support when you really need it. I didn't really have it early on, and that experience really shaped my mission to make sure that others know where to turn for the community, the connection, and the information that we so desperately need. At Share, we really understand that living with MBC touches every part of our lives, not just the medical side, but the emotional and the day-to-day parts too. Our programs are here to support, inform, and give a real sense of connection so that you don't feel like you have to go through this alone. On some of the slides, you'll see a QR code for you to easily explore the programs. So first up, we have peer support groups. Our MBC support groups are peer-led and provide a safe space to share experiences, ask questions, and find support from others that truly understand what it means to live with metastatic breast cancer. We have many groups that meet regularly, and they are all free of charge. Several are facilitated by trained social workers, while others are led by peers within the MBC community. We also offer a support group for Spanish speakers and support group for Mandarin speakers as well. All of our groups take place virtually by Zoom or by telephone, allowing participants to connect no matter where they are. And the focus of our groups are entirely on support, not medical advice. Another cornerstone of Share's MBC programs is navigation and resource support. Our staff can help connect patients with practical resources, connecting to national and local financial resources, insurance education, and local or national support programs. For example, if a patient is struggling with transportation to appointments, questions about insurance, or finding financial assistance, our navigators can provide personalized guidance to help them move them forward. In addition to our support group, SHARE has a range of educational programs and resources. These are designed to complement the support groups and help participants feel empowered, informed, and connected. We'll go through each of these programs in more detail on the next slides. First, I want to highlight our MBC Life. It's a podcast created by and for people living with metastatic breast cancer. It's dedicated to exploring life with metastatic breast cancer, and the episodes cover treatment, mental health, relationships, advocacy, and day-to-day life. You can find us wherever you get your podcasts or on our MBC Life website. Now we're going to talk about our educational webinars and video library. It's another key way that SHARE supports the MBC community. We host live webinars on Zoom throughout the year with leading oncologists, researchers, and advocates who share the latest on treatments, side effect management, clinical trials, and other topics that matter most to us. And the best part about these programs are they are interactive and you can ask questions and engage with the experts in real time. But if you can't join live, don't worry about that because we have every session is recorded and we have our online video library, which you can view at any time. So it's a great way to stay informed and feel a little bit more confident about your care. Next, I wanted to highlight the MBC Brain Mets website. It's a dedicated resource hub created specifically for people living with breast cancer with brain mets and leptomeningeal disease. It's a one-stop place where patients and caregivers can access reliable information, including featured clinical trials, research articles, webinars, patient videos, and blogs. And what makes this website really special is that it's curated by patients for patients. So everything we design is designed with the patient perspective in mind. To keep the community informed, SHARE offers a weekly newsletter and a dedicated MBC webpage. These highlight upcoming programs, educational events, and relevant news. We encourage participants and caregivers to sign up so they never miss updates on support or learning opportunities. And finally, SHARE offers ways for people living with MBC to get involved and to make a difference. You can join our podcasts or webinars. You can mentor others, co-facilitate support groups, or even help shape programs so they better meet the needs of patients and caregivers. Getting involved gives you a chance to connect with peers, find purpose, and use your own experience to help someone else not feel alone. In summary, SHARE's MBC programs focus on connection, education, and empowerment, whether through peer support groups, podcasts, webinars, navigation services, newsletters, or volunteer opportunities. Our goal is to make sure no one with MBC feels alone. I encourage you to visit our website, sign up for our newsletter, and explore our programs or reach out directly with any questions. Thank you again for your time today. I'd be happy to answer any questions or share more about SHARE.
Thank you. Kate, thank you so much. What a wonderful overview. And I know I'm personally excited to dive into that website and resources. Do we have any questions while Kate is here?
Okay.
We get so much out of it. And to your point, we meet Monday nights, and all three of us are there. I think there's a total of probably 25 people that meet on Monday night. Kate, can you hear me? Yeah. And it just enriches our lives, and it always gives us a safety net when we have questions. So I originally went into a support group thinking it felt a little much. And then, so I did go for 2 weeks, and then I thought, well, ignorance is not a good strategy. So instead, I decided to go back and be part of it, and I'm grateful for that decision.
I'll just say she talked me into it. Hi, Kate.
And then she talked me into it. Hi, Kate.
Thank you so much for sharing that. It's so meaningful and to hear from you, and I really appreciate you. Thank you.
Okay, any other questions, comments before we wish Kate a good rest of her day? Okay, thank you again, Kate.
Thank you so much. Thank you. Have a good day, everyone.
And we have an additional opportunity if there were any questions or comments about advocating for yourself before we begin the last section of our day. Mediviver was unfortunately unable to make it today. Yeah, there was a medical emergency. Okay, I will say from the RADONC perspective, I love it when patients bring checklists, or not checklists, but list of questions. To me, I think that's really healthy. It's a great way to ensure you get all your questions answered. As a physician, I'm happy to see it. I want to make sure that we can get through all the questions, so I'll often prioritize those before stuff that I was going to say. And then I think that take-home message of if you can say to yourself, by the end of this visit, I want X, that's a great mentality to have kind of each step of care throughout your journey. So thank you for those great pointers. Okay, so we are going to get into clinical trials, and I have this really cool slide deck here that I'm going to share at the very end, but it has a list of clinical trials at Fred Hutch and contacts. I think all participants will get these slides after the conference, so they're all for metastatic breast cancer patients. You can see if you meet the eligibility criteria, or if you're in cancer support groups with other friends and close ones. Hopefully, this is a resource to empower the community. And I'd like to welcome Dr. Winston Vuong to join me on the stage. So Winston is a fellow radiation oncologist who I work with closely. He's an assistant professor here in the radiation oncology division at Fred Hutch and at the University of Washington School of Medicine. And today, Ben and Winston are going to talk about how to approach and consider a clinical trial. Thanks for having me. So we will begin with Clinical Trials 101 for patients and caregivers. Dr. Vuong is helping lead a new clinical trial. It's kind of just started, so I think he has some fresh perspectives and insights that might be novel for you all to hear. And we'll go through some practical points about you and clinical trials. So I'll kick off the first thing. The way I break it down, and this is actually helpful for residents and trainees as well, is that amongst all of these different studies that we have in clinical trials, at the heart, each one is really answering one of two questions. Can we make outcomes better? or can we reduce harm? There's a lot of verbiage and wording all around that, but basically those are the two main things that we're always interested in exploring, and these are kind of questions that get funded. There's only a finite way to improve outcomes. In terms of receiving treatments, what if we change the order of those treatments? What if we add an additional treatment? What if we increase the dose of a known treatment? And what if we substitute one treatment for a different treatment, using a different systemic therapy? That's really boiling it down. That's what clinical trials are doing. And I think for many patients in metastatic breast cancer, they're going to be trying to answer this first question: can we improve outcomes? Because we're not satisfied with how good outcomes are yet, and we want to make them better. On the flip side, there are some scenarios in medicine where we're doing a great job, and maybe we are actually over-treating patients. Maybe we're causing more side effects than we need to. And we get into this scope of personalized medicine. And so these studies are going to look at, what if I take away a certain treatment? What if I use less dose? Or what if I change the way that something is administered? Maybe instead of, once a day, once a week, or something like that. And in terms of reducing harm, we also think about other aspects of life besides just side effects. There's financial toxicity, there's opportunity costs, time for visits. So these would kind of go into this area of de-escalating care. Lastly, there are phase 1 clinical trials, and we'll go into sort of difference between phase 1, phase 2, and phase 3, but phase 1 are typically experimental, just assessing the safety of a drug. So you may have heard of phase 2 and phase 3 clinical trials. The way I finally, after many years of residency, understood what clinical trials are is I think of it a little bit like a boxing tournament. And you have your, heavyweight gold champion Muhammad Ali, who's standing at the top just waiting for the next challenger to come and take him down. The phase 2 are all the candidates who are trying to prove their worth, trying to say, hey, look, I did this. This is pretty good, huh? And it's only kind of the best phase 2 winners that go on to make it to the phase 3s. The results looked promising enough that there's enough stakeholder buy-in that we're going to support a really big study and compare you versus Muhammad versus the gold standard. And then these two sort of best candidate drugs, they have clinical equipoise, meaning we honestly don't know which one is going to be better. And we're interested to study that in a sort of head-to-head match. So you might see a phase 3 prospective randomized clinical trial. Some will get one, some will get the other. And phase 3 is all about trying to dethrone the current champion. And yeah, I mean, perhaps unsurprisingly, not all phase 3 trials are positive. The defending champion's often pretty strong. So that's my simplified understanding. There are some interesting considerations of being on a clinical trial. Number one, this is not super written, but everyone's going to pay super close attention to you. And sometimes that's nice. There are specific things that always have to get measured, always have to get asked, always have to get reported. And that can be a benefit for you in your care. And if you don't show up for a specific follow-up visit that you were supposed to, it's someone's job to make sure that you have that follow-up visit actually happen, so less things get falling through the cracks. That's one benefit. A consideration, on the other hand, is that it really is unknown whether it's going to be better or not. There is a perhaps less tangible but important benefit that you are helping advance science and you're helping future patients. All the care that you've received has been a product of lots of hard work that went into defining that path for patients with your scenario. Last consideration is eligibility criteria, which we'll get into more, and the importance of trying to maintain the eligibility criteria. Or in order to maintain eligibility criteria, does that limit future treatment options? From radiation oncologists, we often see this at like, can't be on this if you're getting radiation. And I say, okay, let's get the radiation and then we can start it. But once you start it, you can't get the radiation. So for all of us in the room and online, we're pretty much recommending you consider phase 2 and phase 3 trials. Phase 1 clinical trials, like I said, are more experimental. You may be confronted with the opportunity, but understand that there's a very big difference. Phase 1, we don't really know if it's going to help. It, still valid and still advancing science, but if you have the opportunity to consider phase 2 or phase 3 trials first, I would consider those first. So next, Dr. Vuong's gonna switch spots with me.
Great, thanks, Dr. Lee. I think that was a very important breakdown of how to think about clinical trials from the kind of fundamental perspective. Oh, can you hear me okay now? Okay, great. Yeah, Dr. Lee went over a great breakdown of how to think about clinical trials and the different phases that we consider in terms of what's actually happening and what we're trying to accomplish with each of those phases. And it's a constant juggle of what's worth the risks and what are the known risks in each of these phases, right? Where phase 1, we don't really know the risks. This might be a new medication that we've never encountered before outside of animal studies, outside of the lab. Whereas in phase 2, we've passed that point of understanding how safe it could be, and we're trying to monitor to get a better understanding of safety, but also trying to check to see if there's any kind of signal for efficacy and effectiveness in treating patients. And then phase 3, as Dr. Lee had mentioned, was trying to see if we can establish a new standard of care. So what I'm going to present to you all is the PREEMPT study that's just opened at Fred Hutch here. And I want to give you a bit of a backstory before we actually talk about this clinical trial in depth. And if we look at number 1 here, in terms of how this trial was developed, was we had this observation among patients who were hospitalized for pain from cancer in their bones. And as the radiation oncologists, we're often called urgently to see if we can actually help with urgent or emergent treatment to help relieve pain. And whenever we're reviewing images to try to figure out how to target this cancer, it's about 60% of patients that we end up seeing that their cancer was already there for months. And this leads to sort of frustration of wondering how, could we have intervened earlier, right? To prevent a hospitalization or to prevent a flare of pain or a fracture or something. And so that led to a phase 2 clinical trial assessing standard types of radiation. We're not modifying the type of radiation, we're not adding extra, we're not using new technologies, we're using the plain old bread and butter stuff, but trying to see if we can change the timing. And so we already know it's safe, right? So that we can skip phase 1 for this part, and we went straight to phase 2. And this was done with the colleagues over at Memorial Sloan Kettering, where they randomized patients, just randomly 1-to-1, 50% chance of either just continuing on your care as normal or getting radiation to what we define as a high-risk lesion, meaning an area where, if it's not controlled well, could lead to some kind of complication, including fracture, compression of nerves, loss of function, need for surgery, or hospitalization. And what we saw from that clinical trial was that if patients got the radiation treatment to these high-risk lesions, we reduced the chance of any kind of skeletal-related event down from about 30% down to about 2%. So Now, keep in mind, this is in all types of cancers, not necessarily just breast cancer. And because this was that initial signal, right, from the phase 2, that there could be something here that we're on to, we have to explore further to see if we can actually validate this in a larger setting and understand who might benefit best from prophylactic or preemptive radiation treatment, and hence the name for the phase 3 trial. So this is the preempt study through the NRG cooperative group, and this is activated internationally, so across America, Australia, and I believe in Canada. And this is an expansion of that initial phase 2 trial. So it's a randomized phase 3 trial of prophylactic preventative radiation versus standard of care for high-risk asymptomatic bone metastases. And the primary endpoint for us is to see whether or not radiation can actually reduce these complications of bone metastases. There are other endpoints, there are kind of technical points, but we are looking to see if we can help improve longevity, if we are able to prevent, a major hospitalization or something like it. This is kind of a brief overview, just looking at a skeleton of where are the different high-risk areas, and that's things like the spine, the bones, like the weight-bearing bones in our legs or arms, or any kind of big areas of cancer. And we're thinking that if we can target these areas, maybe again, we can prevent any kind of complications from it. So this is something that is underway now, open at Fred Hutch. You can ask your local oncologist if it's something that, could be applicable to your situation. But the main point of sharing this is that a clinical trial, ignoring this one in particular, is born from either an observation from the doctors that, hey, we see patients struggling for X, Y, Z reason, and we have to find some way of improving on that. And that's to show you that the people behind the scenes are trying to figure out how do we help patients. And this is a radiation trial, but when you're considering a drug trial, for instance, that's born from the efforts of laboratory scientists. And having been on that side, I can tell you that anyone you ask in the lab, they want their work to mean something. They want those hours that they've spent, with those cells, with those animals, to actually translate in helping people, because it could be their sister, their mother, their aunt, and they want those efforts and hours to go towards something. So the heart is there in terms of finding or trying to make something better from these clinical trials, but it's a long process, and I'm glad that at least you're able to kind of get a little bit of the behind the scenes of how these are developed and how we think about clinical trials. So we'll next go over 2 different ways that you might encounter a clinical trial, and we'll hand the mic back to Dr. Lee.
I'll stay here, cool. So you may be able to guess, but the first way is that your oncologist presents it to you. Hi, Miss Lee. I think that you'd be a great candidate for this study. The second is that you search and discover one, and then you want to bring it to your oncologist's attention. I think in this day where there's so much information accessible, this is an increasingly common scenario. And it's good. Even bringing up, I had this long conversation with ChatGPT, print out all the notes, what do you think? We want to be furthering your knowledge, not just repeating stuff that you've already read. So, and if we don't know, it pushes us to learn so we can provide better service to you and others. We'll go through a kind of a practice scenario about maybe your oncologist presenting one to you so you can see how scary or not it is. I'll pretend to be the patient, and Dr. Vuong doesn't have to pretend, but he'll be my amazing radiation oncologist. So let's pull up 2 chairs, maybe.
Sure.
This is going to be so entertaining. Sure, yeah. Okay, I don't know if we're sitting in a good place for the online people to see us. Yeah, being adjusted. Oh, wow, that's amazing. Okay, so in this scenario, Dr. Vuong's the radiation oncologist. I'm the patient, and Dr. Vuong, maybe you've just looked at my latest PET scan, and you can talk to me about maybe me being a candidate for the preempt.
Hello? Great, thank you. Well, famously, so as we had discussed, your PET scan does show us that there are some areas of concern. We were suspecting this based on some areas that were noticed to be more painful in the last couple of weeks. And I think this imaging has confirmed for us that we are seeing some areas that suggest this cancer may have gone to other parts of the body. There are many things to do about this. There's, of course, standard medications we can consider with the medical oncologist. And based on your symptoms, one of the standards of care that we can offer is radiation treatment that's focused and a limited number of sessions meant to help relieve the pain that you've been feeling. And separately, there are some areas of cancer where it's very small, but they're in sensitive areas that if it were to keep growing, it might end up causing some problems with your quality of life or your function. And so we have a clinical trial that's aimed at possibly preventing those problems if you're interested.
So what you're saying is that the PET scan shows that there's multiple spots. Some of these spots you were expecting because I had been talking about this pain on my sternum and this pain on my shoulder. But there's also some other spots. I haven't really been feeling anything else. And you're saying that I can do one thing or another?
Yeah, that's a tricky thing about cancer. It's that oftentimes cancer can grow even in a way that we can't feel. It can occur in places that we would never guess. And unfortunately, we do see that in some areas here, such as the femur or the long bone in the leg. And from what you've told me earlier in our visit, you've been staying active, you've been able to run and jog without issue, thankfully. And the goal here is to hopefully maintain your quality of life, if not somehow improve it, or at least preventing problems from cancer getting worse.
Okay. Well, yeah, thank you. It sounds like you've taken some time to review things before this visit, and you've given this some thought. And yeah, I'm open to hearing more about what you recommend.
So I would definitely recommend palliative radiation, which is radiation meant to help with pain to the areas that are hurting. And then for the areas that are not, like that left leg area, we have an optional clinical trial. Again, this is an opportunity to enroll into a study that helps us understand better how to help patients in the future. And there's a possibility that we could help you, but we're just not sure because of the nature of the trial. So this is a phase 3 trial, which means that it's randomized. It's meant to confirm or at least help us better understand the results from earlier studies. And this is a randomized trial comparing radiation before problems occur or waiting until something happens to radiate. And again, I can't guarantee that you're going to get radiation because this is a randomized trial. And it's randomized so that we can help reduce the biases as we're trying to figure out whether or not this actually helps patients.
I see. When I hear the word clinical trial, based on my past experiences, what my grandma went through and stuff, I know that they were experimenting on people and sometimes, and I just feel a little nervous. Am I going to be like a guinea pig?
It's understandable to feel that way because a clinical trial inherently is experimental in nature, right? And there's a dark history to clinical trials. And that dark history has led to a lot of developments to ensure the safety of patients. And there are so many committees that we have to go through to ensure that we minimize the harm to patients and to make sure that there's independent monitoring of clinical trials to make sure that even if the investigators, the people who have a vested interest in the trial are trying to accrue, we're doing so in a way that's ethical and safe for patients, and it has to continuously be reviewed. So this clinical trial that I'm presenting to you is one of those such trials that has gone through that vetting process. And while I can't guarantee that you won't get any side effects from treatment, because there are inherently side effects to consider, they're at least deemed to be reasonable for the situation we're considering.
Wow. It sounds like you've had to go through a lot of conversations, meetings, documents, forms, ethical review board committees, and it sounds like they all finally approved this, and now it's ready for patients.
Yeah, and that's what it takes. Because any little bit that we overlook potentially as people who are just wanting to get the trial started, we need another set of eyes or 20 to make sure that we're getting everything done properly and safely for patients.
Okay. And if I say yes to the clinical trial, what happens next? And does it cost money?
Yeah, so if you were interested in a clinical trial, so we would have the study coordinator reach out to you to provide you with information so you can review what we understand about the clinical trial, the consent, the potential risks and potential benefits of it. And depending on the structure of the trial, if it's asking you to get additional imaging or get additional follow-ups, that might dictate whether or not there are some financial consequences for the trial. But that's something that should be clarified with the oncologist, because depending on the type of trial, there could be coverage from the study sponsor or dedicated funding from the institution. But that's something to explore further with your particular oncologist in particular trial.
I see. So you're saying that some clinical trials do have funding and sponsorship so that participating in it could be no cost to a patient?
Correct, yeah. Oftentimes, so these larger trials, if there is a lot of funding for the trial itself, that will cover many of the costs for patients. And there will still be the standard costs of the routine clinical checkups with your physician, just to make sure that you're doing okay and that toxicities are managed well, if there are any, and to maintain at the bare minimum the standard of care.
Okay, and you mentioned potential benefits of the clinical trial. Could you clarify a little bit more what that means for me?
Yeah, so in your particular case, the potential benefits are to prevent a fracture, to prevent the need for surgery, or hospitalization, to potentially prolong longevity through this clinical trial. And in the phase 3 setting, we're often looking for a signal for the improvement of longevity, if not effectiveness of the drug.
Well, that sounds great. Can I just get the treatment without being randomized?
So, depending on the trial, it's technically feasible, but the problem is that the reason why it's a clinical trial is because we don't know if it's actually better or worse than standard of care. There has to be something that we call from our side equipoise, meaning that there has to be at minimum an even level of risk, that you're not taking on excess risk. And if we knew for a fact that something's already better, why would we hold it back, right? We would offer it to you already. So if you were to want a treatment off of a clinical trial, we just don't know if it's actually better or worse than what we would do otherwise.
And are you saying that if I asked for care that hasn't been proven in a study to be beneficial, that my insurance company might not approve it?
So that's what leads to some of the financial considerations for a clinical trial. And that's why many of these studies have financial backing to help offset the financial burden on patients. For this particular trial, you can standardly get this type of radiation approved because we're not investigating a new type of radiation. We're not using a prolonged schedule. So this is something that I anticipate to be readily approved by insurance as sort of a standard of care or within the edges of standard of care. We're trying to see if that edge case is just as good, if not better, than the standard.
Wow, radiation oncology seems so cool. It's not subject to some of the same annoying rules and regulations as drugs. Is this why you chose radiation oncology, Dr. Vuong?
It's a great field where we can help people, as you've experienced.
Can you pat my back?
We'll take care of you.
Good answer. Okay. Well, I want to make sure, so if I sign my name, am I locked in? Like, have I given up all agency, or could I back out if I don't feel comfortable?
That's a great question. So with anything throughout your care, let alone a clinical trial, you always have the right to change plans, depending on what fits your needs, depending on your situation, because things happen. And particularly within a clinical trial, it is always your right to withdraw from a clinical trial or to transition the care plan to doing standard of care instead.
And will my oncologist kind of be biased to continue the clinical trial, even if it seems like I'm not doing good and maybe I would benefit from going off of it?
It's a constant assessment of how patients are doing. And just speaking from standard oncologic practices, we would never put a patient through something that we didn't think was worth going through. And there comes that aspect of trust in your doctor, right? To trust that they have your best interest in mind and heart. So there's always an exit to doing something that doesn't seem beneficial. Because while it might help patients in general, maybe that might not be the right strategy for your case or another patient's case, because everyone's bodies are different, everyone's reactions are different, so the doctor has to take that into account. And also separately, as part of a clinical trial, as I was mentioning, there's this independent review committee, and they have to assess for the safety and efficacy at different time points throughout the clinical trial. So if at some point they see that this clinical trial is either appearing futile, not effective as we would have hoped, or more toxic with more side effects than we would have expected, then that's a signal to shut down the clinical trial early, to reduce the harm to patients and to prioritize maintaining safety and quality of life.
Well, thank you, Dr. Vuong. You've done a really nice job of answering all my questions. I trust you, and you've done such a nice job of taking care of me. And yeah, I'm interested in meeting with the research coordinator to see about getting on the clinical trial. And thanks for thinking of me and making this opportunity.
Great, I appreciate your trust in us. Great, thanks.
I like hugs. Okay, give it up again for Dr. Vuong. So yeah, as you saw, every conversation is tailored, it's real. But if you're being offered a clinical trial, your oncologist is being thoughtful and is thinking about you. It's trying to create opportunities. We'll never force you to do something that you don't feel comfortable to do. But hopefully here at Fred Hutch and other large academic centers, community centers, we're trying to increase opportunities for clinical trials everywhere. Don't feel shy to bring up something that you read to a doctor. Just a little point of sanity. There's so much information out there. There's a quote I just heard. We used to be starving for information. Now we're starving for clarity. So think of, yes. Hopefully doctor visits can be a nice place to find some clarity, but please don't be shy to bring your questions. There's a website of current clinical trials here at Fred Hutch, and you can search and filter for breast cancer and see what's there. We also have a slide deck, like I said, that we'll distribute to everyone here at the end of the conference. And then just, to recap, all clinical trials are answering either the question, can we improve outcomes or can we reduce harms? You can encounter this either a doctor presenting it to you or you presenting it to your doctor. Phase 2 is exploring promising candidates. Phase 3 is attempting to dethrone the current standard of care. Eligibility criteria is very important in your search. If you don't meet the eligibility criteria, your doctor cannot bend backwards for you. They can't change your age. Some things yet, I don't know. And hopefully through conversation you recognize different types of clinical trials that might be appropriate for you. So that is our talk about clinical trials. And we are right on time. Lunchtime, just kidding. So I want to give a special thanks to everyone behind the scenes in organizing the event today. So Ritu, we have Justin, there's Meredith too, who you saw, and Alana, who has been doing a great job of making sure the virtual audience has all their questions brought up and shared in the room. So thank you to everyone. Our Fred Hutch philanthropy team also came and set up a table. So we've had a lot of volunteers just come together to try to make this event as meaningful for you as we can. Thank you. We would love to hear how you liked the event today. We used these responses last year to help design this year, and we're hoping we can keep this up. This is the second year in a row that we've had it. Would love to keep on making it a third and, forever. So yeah, thank you again so much. It's been an honor and a privilege to help introduce you to the speakers today.
And I just wanted to share that in a post-event email that goes out to you all, we'll include a link to the recording, feedback form, supportive care services, and then that link to the clinical trials page, as well as the deck that Ben was just referring to. No, yeah.
Oh yeah, sure.
I don't have a question. Well, I do have a question, but my main thing is I want to put in a word for trials. I've lost count of how many. I was first diagnosed in 2008, and during that time I was the Aloxi, the Abraxane, the bisphosphonate, and those were all phase 2, I believe, when I was in them. I was invited to the STEMVAC breast cancer vaccine phase 1, and boy, did I have questions and fears about phase 1. But I talked to everybody, at the supervisor and everybody, all my questions, and was reassured that there was a lot, even though this particular one was new, there was a lot of vaccine experience in that research team. I don't think my insurance was ever charged. One study I was in, which was comparing regular digital mammograms to this new thing that GE was promoting, I was paid $100, and that just seemed wrong, actually. I'm not doing this for money. I'm doing this for 2 reasons. For possibly my own benefit, I think I benefited. I think that's why I was stage 3C in 2008, and only a few years ago did my metastases show up. I think I benefited from all of those trials I was in, and everybody was fabulous. I ask about trials now. I think that because everything seems to be stable, and like I said before, I'm not having bone pain. I think that's why I can't get in a trial now. You don't mess with what seems to be working, I think. But yeah, I encourage everybody to take part in trials. Yeah. And only one, none of them, I hear from people, but I don't want to get a placebo. None of them had a placebo. They weren't going to stop treatment for anybody in the trial. It was comparing treatments, or in the bisphosphonate trial, there were 3 arms, and I happened to get in, I think, the best one, the one with the less side effects, although it's not patented, so the FDA, nobody will ever apply for FDA. It's a European bisphosphonate. But I, during those 3 years, had that benefit. I just really encourage people.
Thank you. That's really wonderful to hear.
I'm that person everybody's rolling their eyes at who's always going to comment. This isn't specifically about a clinical trial, but I don't know if you've heard about Take Part Northwest, which is, so it's on Fred Hutch's website. So this is for everybody to, get out their phones and look it up. Fred Hutch is doing this thing called Take Part, and it's all one word. Take capital I and P part capitalized. Take Part Northwest, and it's a voluntary, I don't really want to say it's a study, but you can voluntarily donate or leave a sample of either your blood or your tissue or, something that comes out of you that, they take for whatever. And it's stored and kept, I don't know how long, all that stuff. But you get to donate a part of your DNA and yourself so it can be used for future studies, not just breast cancer. There's studies for, other things, dementia and Alzheimer's, but for Fred Hutch's breast cancer. And if you're not signed up to get the emails and stuff from the Hutch, that's how I learned about it, was I get the little newsletters. And so I started reading about it, and they just take one extra vial. So I asked my oncologist about it. She hadn't heard about it either. So then she forwarded me on to those people. And right now, they told me it's just for people who receive services here. I get services at Evergreen, but I'm going to come down here for my next blood draw so they can and it's only a one-time thing they need with a blood draw. They can take the vial and store me somewhere wherever for whenever. And maybe it'll be that one, put the bait on the hook and catch the sea monster and get it out of the ocean, So for people who are interested in a clinical trial to help with science and humanity, this isn't a clinical trial, but it's just a way to donate what they're taking anyway, so.
And that is a very new thing, so within the last couple months, yeah.
I just wanted to make a comment on clinical trials. Number one, oftentimes we're within organizations and they tend to know about the clinical trials that are within their organization. And so it's not to make a pitch that you go looking for yourself, but that there is a benefit for doing some research on your own about clinical trials. And there's a few organizations online, nonprofits, that will help you look for clinical trials across the country that you might be eligible for. They will check your eligibility criteria. And I think I did this for a person that I'm helping now, and locally in our Southern California, there were no clinical trials, but we did find a clinical trial for her at UCSF. So that I was just, there is a benefit to be looking outside of your organization.
Yeah, I just wanted to clarify, and I apologize if you already answered this. I'm not a patient at Fred Hutch, I'm a patient at Kaiser. Am I still eligible to do trials at Fred Hutch?
I think so.
You have to become a patient, I think, or get referred. You have to get referred over.
Yeah, I think, so I have not designed a clinical trial, but my understanding is that there's certain institutions that are participating in clinical trials. In order to be part of that clinical trial, that institution has to do a lot of paperwork. It has to get approved. Like it can't just be, yeah, let's do it. So some institutions will try to say which clinical trials we are enrolled with. And then if you wanted to participate in one of those clinical trials, you have to, I think, get established as a patient there. And then once you have that first visit, then I think you could get on it. I think Dr. Vuong's going to clarify.
Yeah, so what we've seen from our clinics is that we offer these multidisciplinary clinics where patients come in for either an initial evaluation or a second opinion. And oftentimes at those visits, we'll have a list of clinical trials that are available. And if you're a patient who's outside of our system, all that it takes is to ask your oncologist or physician, hey, can I get a referral to Fred Hutch or wherever institution you're looking at because of a clinical trial that is not currently offered through Kaiser or through Evergreen or wherever it might be. And they should be supportive of that because it's something that is presently not offered through whatever healthcare system you're in, right? So you can always ask for that. And if you run into troubles, you can contact Fred Hutch and just ask for like a kind of nurse navigator person to get information about how to get involved with clinical trials as someone who's outside the system currently.
Can I ask a follow-up to that? If that happens, do I have to stop my treatment at Kaiser because I become a patient at Fred Hutch?
Not necessarily.
Okay.
So some people come here just for the purpose of a clinical trial, and they actually go back to their home institution to continue whatever they're getting if the trial is meant to be an addition, right? So if a trial is supposed to be something that replaces what you're currently getting, that's a different situation. But great question.
So just got a question on trials specifically. What drives an institution or an entire medical group to have a clinical trial at their specific facility, right? So like with any trial, as a power or your sampling goes up, your specificity narrows, so by a higher margin that this specific drug or thing does or does not work, right? So like Fred Hutch is only, part of very few National Cancer Institutes, right? I think there's only like 41 in the nation or something like that. But so what drives, I guess, Fred Hutch to do a trial versus another institute where, let's say in this case, like metastatic breast cancer, like we see something in, it doesn't matter, like let's say Johns Hopkins, for example, instead of having a person fly out there, why doesn't Fred Hutch do it here? Or if you live in let's say Stanford, like why doesn't Stanford do it? So it's just an education question.
I can comment on that. So clinical trials, like we were mentioning, go through a lot of committees. And one such committee is whether or not we're able to fit the needs of our patients for a particular clinical trial. To give one perspective, not necessarily in breast cancer, but in lung cancer, for instance, there's an entity of lung cancer where some have what we call driver mutations and some that don't. And certain areas of the US actually have more cases of driver mutation lung cancer as opposed to not. And so the oncologist at that institution might say, hey, we actually don't have that many patients and we can't meaningfully enroll enough patients to contribute to the clinical trial. Or maybe the drug that's being offered actually wouldn't fit the types of patients we see here. So that's one consideration. And the other is logistically, are we able to do this? If it's a totally new technology, if it's a new process that has to be undertaken, then we might not be able to do it, just feasibly speaking. And speaking from the realm of brain metastases, there's this concept of, can we radiate before surgery to prevent any kind of spillage of cancer at the time of surgery? And that's something that's been difficult to open at many institutions because of the coordination that needs to happen between making sure patients see the radiation oncologist first, get set up for treatment, and then go straight to surgery. And so there's those logistics, there's the patient needs aspect of it, and also the interest of the physicians at the institution. So it's a lot of different things that go into it.
Yeah, thank you. Really good questions. I do want to be respectful of the rest of this amazing Saturday. We're a little bit over time, but thank you, everyone. I hope that this brought value to you, whether you're a Fred Hutch patient or not. We really care about everyone with metastatic breast cancer. So go out there, have a good day, a good week. Be in touch with us. Share what you learned with others. And thank you again.